Down here. So we're going to talk about pediatrics. I looked through 3 different PowerPoints, the current AEMT, the current AEMT, and the last edition EMT, and all 3 of them have, I don't get it. All 3 of them are a little different. You know, the last edition EMT presented a few things really well. This one presents other things really well. I don't know. It was almost a coin flip. So here we are. We're going to use the AEMT chapter 44. This will go, I'll send you guys the link to it afterwards. Sometime tomorrow, it'll go up on YouTube as well. So you can go back through and listen again if you want. I got to send it out to Danielle, because she's at a wake tonight. So the other, I think it's 2 chapters for this week, should be finished and online either tomorrow afternoon or Friday morning. I'm putting finishing touches on those. So that'll get us through everything we need to do this week. All right, so pediatrics. Come on. So one of the things, I guess, probably it's hard to say it's the most important thing. For us, I think it is to understand and accept the fact that these are stressful calls for a number of reasons. Nobody wants to see a hurt kid, you know, unless the kid really deserves it, and that's awful to say, and you know, that's a horrible black joke. Anyways, but nobody wants to see a hurt kid. Parents and family members and siblings and grandparents are losing their minds. Police officers, fire, everybody around us. One of the reasons I've seen that people struggle so much with it is they look at this kid and they see their kid. Even if they don't have kids, they look at this kid and think of it like, and my biggest recommendation is to just stop for a second, look at this child and say, wow, this sucks. Thank God it's not mine. And then do everything you can, you know. Don't let yourself see your kid's face in this position. That makes it harder to do at the time, as well as harder to deal with after the fact. All right. And there is nothing wrong with sitting down with parents and crying. Nothing wrong at all. Whether it's because there's nothing you can do about it, or after the call, you're at the ER, you're whatever. Okay. There's nothing wrong with that. If you can't allow yourself to sit and cry with somebody over something like this, then that almost bothers me more. You know, you gotta let it out at some point. You know, and if it doesn't bother you that much, don't let that bother you either. And some people do. They feel guilty because, well, shit, how come I don't feel bad about this? Well, people handle things different. People have different triggers, okay? But know that this is one of them for a lot of people. Excuse me. Also remember, there's a great phrase that kids are not just little adults, right? They are nothing like us. Emotionally, physically, you know, physiologically, anatomically, none of it. I mean, they look like miniature versions of us, but they function differently. And being able to recognize that through different stages and different ages is going to help you. And being suspicious, you know, mechanism of injury. This kid should be hurt. He looks great. He should be hurt. Stick with that thought in your head. He should be hurt. And hopefully that way you don't miss something. Okay. Now, one of the things that the EMT chapter had that I really liked a lot, and I thought about cutting and pasting and all that, but is they had a diagram of an infant about this size, a toddler, or not a toddler, I'm sorry, like an adolescent, like 12-year-old, and then an adult. And they had bottles of soda in front of them representing blood volume. And this infant, a little bit smaller than this kiddo, is roughly a 12-ounce can of soda for blood volume. An adult, my size adult, roughly 5 liters of fluid, of blood. So that's 2.5 2-liter bottles. And then that 12-year-old's roughly in the middle, a liter, liter and a half. So with an adult, that scalp injury that's bleeding like a stuck pig is not nearly as dangerous a threat as it is that same cut on that 18-month-old. Okay, so understanding that they have less blood. They start out with lower blood pressure. They start out with faster heart rates, faster respiratory rates. So when we are, assessing them, we need to be comfortable with how much faster is normal, how much is, like Goldilocks and Three Bears. Oh, too fast, too slow, just right. Because those numbers are different depending on how big you are or little you are. Their head's proportionately bigger, and it's on top of a weaker neck. So, that head weighs something like a quarter of all their, 20 or 25% of their body weight. And it's on an immature structure, the neck muscles and the cervical spine. And so they can't hold it up. If they can't hold their head up, how are they supposed to control their head when they fall, get dropped, bouncing in a car seat? They can't. All right. So the head bounces around a lot more. They don't have the temperature control. That part of the brain is not functioning at this size. So there's probably my favorite movie in the world is Grosse Point Blank. And, it's about a hitman going back for his 10-year high school reunion. And he's sitting at this table. The dude's killed, like, what was it? The president of Paraguay with a fork. But there's a friend from high school hands him a baby. And he's just sitting there holding it out, just like shaking, staring at it, scared to death of this baby. And he makes a comment, I imagine they're fairly susceptible to the elements. And it just cracked me up. And so I play that a lot in classes, at just that little 15-second clip. Tomorrow at work, Google it. Grosse Point Blank baby scene. It's got like 7 billion hits, half of them are mine. But watch the look on his face. That's us on our first baby call. Just like, terrified. And that's acceptable. But they are susceptible to the elements, right? They can't control body heat. They have smaller airways and a bigger tongue in the middle of it. So there's a lot less room for error. They dehydrate really easily, right? So like you and I our brain and all the chemoreceptors and baroreceptors and all that stuff say, hey, I've put out a bunch of urine. I had a bunch of coffee this morning. I've peed a lot. I haven't really drank anything. My fluid level's a little low. It says, hey, dumbass, you're thirsty. And you get up and you grab your water bottle and you drink until you're not thirsty. These kids can't do that. Okay. Their volume's already lower than ours is to start with too. So they dehydrate easily. Think about your respiratory rate, right? Your respiratory drive, your ventilations. Part of what you're exhaling is water, right? Water is a byproduct of aerobic metabolism. So if I'm breathing 12 times a minute, I'm exhaling X amount of water. If I'm breathing 24 times a minute, I'm exhaling twice as much water, right? So this little kiddo, normal respiratory rate for this kid is 25 to 50, right? As a a newborn. So, or as an infant rather. So if you're at 25 and you get a little sick and you don't feel a little good, and you're breathing at 40 or 45 or 50, same thing. They will exhale twice as much water. And so they get behind the curve super fast. Little kids' extremities. They, it could be cold. It could be because they're sick. They could have a fever. And their skin will look mottled. And what I mean by mottled is this kind of like you've got that like pale background color to it, and then you've got almost like dark red, purplish splotches kind of scattered throughout that area. And with adults, you only see that when they're shocky, or you'll see it like when they're dead. You roll them up, they've been laying on the floor for 30 minutes dead. You log roll them, look at their back, and you'll see everything that's dependent, everything that's lower than the heart will take on that mottled look. Kids just do it though. It's important to note because it's not normal, but it doesn't mean they're dead, So it could be cold, could be hot, could be feverish, could be just sick, whatever. So we do want to look at skin color when we assess these kiddos. Age groups, infants. So a month to a year. Neonates, from the time of birth, right at the end of the second stage of labor, not the fourth. All right, so from birth to 1 year to 1 month is neonate. Infants are 1 month to 1 year. They don't have an immune system yet. Where do they get their immunity from? Well, hopefully they're being breastfed, because that's where kids get immunity, is from mom through breast milk. So if they're not being breastfed, they're probably don't have any immunity to stuff. That's one of the benefits of breastfeeding. Liver is huge within the abdomen compared to ours, which means that ours is easy to damage, but if theirs is huge in comparison, it's easier to damage their liver. And we have a lot more muscle and a lot more fat and a thicker skin than they do, so we can protect those organs better than they can. It's kind of like, whatever your religious beliefs are, but so like in mine, God made these kids bendable for a reason. It's almost like, well, they're going to fall down. Kids learning to walk and run fall down a lot. Kids running with their friends fall down a lot. So if I make them a little bendable, they don't get hurt as much, right? I mean, they don't break. Like you'll see a kid fall on a hillside, right? They're running down a hill with a buddy and they go tumbling head over a tea kettle. That'd be a helicopter flight for me. But this kid just gets up at the bottom and giggles and runs away, So they bend. The downside to that are their ribs bend. So if you look at our ribs as adults, we have 10 ribs, 10 pairs of ribs that are connected in the back and the front by cartilage, either to the sternum, to cartilage connected, big, chunks of sternum to the cartilage, or to the spine. Then we have 2 floating ribs at the bottom, the 11th and 12th rib. If you punch me hard enough to break a rib and puncture my liver or spleen, there's going to be some signs and symptoms that go with that. Bruising, deformity, feel the rib, you can feel it's broken, things like that. Little kids' ribs bend, so you could fall or he could get hit, and that rib will actually kind of like bend in and could into the liver, into the spleen, slide right back out. No external evidence of trauma at all, but the kid's got some belly pain. Oh, well, shit, he's gassy, right? Little kids, colicky babies, he's gassy. No, he's not fucking gassy, he's bleeding from his spleen. Okay, so we gotta keep that in mind. Kidneys, they're efficient, but they're not quite up to speed yet. Skeletal muscle mass is small, right? Little kids are infants, they're weak. They can't hold themselves up yet. They don't have that musculoskeletal, neuromusculoskeletal capabilities yet. So they can't protect themselves as well. They fall, yeah, they bounce, but they can't catch themselves like we do. You know, I mean, in my mind, it's better to fall, break a wrist than smash my forehead on the floor. You know, so they're gonna hit everything. Just they're gonna pile up on the floor, and they can't protect their internal organs because they don't have that muscle mass to block that punch, to protect them when they fall. All right, covered that first one. Surface area. Our skin is our largest organ, so is theirs. Exponentially, though, in comparison to the rest of their body, their skin is larger in ratio to their body than ours is. So, heat and cold, right? That plays a part in their ability to maintain thermogenesis, okay? So they got to be kept warm. They are susceptible to the environments. One of my other favorite lines as he's walking into this thing is, I wish I had my gun, and his date looks at him and goes, what? He goes, I said it should be fun. I think of that line a lot. Anyways, like every time I go in a house. Infants, airway obstruction. Very easy, right? Again, the airway's small, the tongue is much larger. The nose is small and soft. The lungs are fragile. Pretty easy to damage them. Chest rise and fall when you're ventilating a kid. You can pop a kid's lung super easy ventilating them, okay? So just gentle, looking for chest rise, chest fall. Also, though, their lungs can be damaged very easily by impacts with other things as well. Their infants and kids as a whole, they compensate really well for X amount of time, you know? They look really good for this amount of time, and then they just crash. Their little hearts only have so much mileage on them compared to mine. Their kidneys are newer, their liver's newer, their ability, right? All that stuff's newer and doesn't have the mileage. It doesn't have the abuse, the years of alcoholism and smoking and drugs and fat and all that crap. Me, you know, I have my near fatal event, and I'm going to do okay. I'm going to compensate, and then you're going to start to see me decompensate. The speed at which I decompensate is certainly affected by what my injuries are, but I'll compensate a little bit, and then I'll start down the slope before, and give you some warning before I fall off the edge. These kids are going to look good, and they're just going to step off the freaking cliff like a lemming. Gone. Key phrase, gone, okay? So they code cardiac arrest, the majority of them is either respiratory arrest or hypovolemia. You know, these kids don't generally have VFib cardiac arrest. These kids don't generally have myocardial infarction. That's not to say they can't. The numbers are so small percentage-wise. So it's super important to recognize this kid's having trouble breathing. You know, this kid's in respiratory distress, and stop it before it becomes respiratory failure. This kid's dehydrated. He's got whatever infection you want to think of, whether it be a cellulitis or a bronchiolitis or a cold or, you know, COVID, or it doesn't matter what. He's breathing fast. He's exhaling a lot more water. He's got a fever, so his body is bringing more sweat to the surface so that it can evaporate from the last set of chapters and cool him off. And he's not eating or drinking because he feels like shit. So, you know, what is a good look hydration-wise, right? Good cap refill. Skin tenting. When you, and you can do this with any aged person, by the way, but if you take the skin and you pinch it up a little bit and let go, it should go flat, right? My skin does this pretty well. I'm super hydrated today. Gone. It should go back to normal within 2 seconds. So just keep that 2 seconds in your mind. Cap refill, skin tenting. If you pinch it up and that skin stays pinched up a little bit, we call that tenting. The overall condition that we're checking is for what's called turgor. Turgor, skin turgor. Okay. So tenting shows dehydration and or bleeding. Poor feeding, right? They don't feel good. They don't eat. They don't breastfeed. They don't drink their bottles. They don't eat their applesauce, whatever it is. It does not take a lot of vomiting and diarrhea to make a little kid dehydrated. And again, fever, between the whole breathing fast and sweating, that will do it too. Less able to fight infection. So, I'm not a mom, obviously, but, there's kind of two schools of thought amongst mothers. One, I want to breastfeed as long as I can. And the other is, I don't want to breastfeed at all because I don't want big stretch marks on my boobs. I've met both of these people, I've had friends that have both, but that's kind of selfish in my mind because that makes this kid healthier. Breast milk is the best, unless there's something wrong with mom, it is the best food available for that kid, right? And it's how they get their immune system built up. So crying, right? The reason kids get shaken, they're crying and they won't stop crying. There's a freaking reason, they don't feel good, something hurts, they miss mom and dad, they're upset because now they don't know who they're with, whatever it is. That it's the only way they can talk for a while. It's the only way they can communicate, to let you know there's something going on. All right, so neonates, 0 to 1 month, 1 month to 1 year, infants, and 1 month to 1 year infants, toddlers 1 to 3. Now, when we look at these age groups, my brain's going faster than my mouth is right now. Don't forget that these are not cut and dry. Like, oh, day 366 is your first birthday, right? That's a year. That's 1 year old. You got through 365. Now you're a year old. Well, now you're a toddler, not an infant. It doesn't work that way. You can have a little bit one way or the other. Kids age and mature differently. You can have a set of twins and one will do things quicker than the other one will. Okay. So these are generic guidelines. Preschoolers, 3 to 6. These, by the way, are very typical type test questions. Up to 6 years old, well, even more than that, but their heads are still bigger proportionately. Their airways are still smaller. And don't forget, we talked about, well, the A's and I talked about this last night, their head's bigger. So when they're supine and you need to put a blanket or a towel underneath their shoulders. You want to get their head. So, if their head's bigger and they're lying flat, it'll do this to the airway. But if you put something under the shoulders and you allow the head to rest back, it'll help keep that airway in more neutral position. Okay. Vulnerable to communicable diseases. Ear infections are super common. And lower respiratory infections, super common also. Those of you who have kids know this from when you start sending them to either daycare or kindergarten or nursery school or first grade. For the first 2 weeks, they're all sick, right? If you don't have kids and you've been to college or basic training or, right, you are sick for the first 2 weeks because we all come together with immune to different things, right? What our environment has been, we're immune to those things. Now we're coming into an environment where other people are bringing different bugs and we all get it until we build up our immunity to it. Same thing with kids, especially when they start going to schools, daycares, whatnot, okay? And also think about this. Well, up until COVID, right? Everybody wants to kiss babies. I mean, God, it's the politician's wet dream. I get to kiss a baby on TV. Not anymore, you don't, right? You kiss my baby, I'll stab you in the neck. I don't, but people still want to do it, right? You still want to kiss that baby. Oh, they're so cute. Let me get it. No, away from my kid. All right, now, some fairly common disease processes. Croup, that seal bark when they cough. Their upper airway is inflamed and raw, and it hurts, and they're swelling. It's swollen. It's viral. Everybody brings their kid to the ER, and we go, as long as the kid's breathing okay, doesn't need steroids or nebulizers, things like that. We're just like, yeah, go home. He'll be okay. But some things you can do for croup: cold air, cool air, not cold, not like 3 degrees yesterday morning cold, but cool air. Think about your ankle. You twist your ankle and you have some swelling in your ankle. What do? You elevate it and you put an ice pack on it. Well, you can't fill the kid's airway with ice, but cool air will act kind of like an ice pack. It will help. My oldest boy, Brian, I remember one trip to Ohio in January. He got croup really bad right after we got there. And we were in this hotel room, right around the corner from my in-laws. And I spent 3 nights sleeping on the balcony, wrapped up in a comforter with Brian on my chest. He was 2 or 3 at the time. And as soon as we go out on the deck at night, he wouldn't do it during the day. This is very common pattern. At night, it gets worse. We go out, sit on the balcony, and boom, he'd go to sleep. And I'd sit there staring at the traffic going by the hotel for, 9 hours. It was great, but it worked for him. Some kids do better with a little moist steam. You take them into a shower. Most of the time, you go outside and it's almost instant, okay? So we can do that. Bronchiolitis. Bronchiolitis is basically bronchitis in a little kid. I'm not really 100% sure why they call it something different. It presents the same way. Wheezy, rhonchi scattered throughout, coughing up green and yellow junk, right? Feverish. They get real feverish with it. Whereas adult bronchitis, I don't think we get quite as sick as they do. But so for the A's, the kid's wheezy, nebulizer, right? Albuterol, Duoneb. Pneumonias. And bronchiolitis can be viral or bacterial. They usually end up on an antibiotic. Pneumonia can be viral, bacterial, or fungal. Think of that. One of my favorite foods on the world is fungus, mushrooms. So when I think of fungal pneumonia, literally picture mushrooms growing in their lungs. It's kind of ugly. So short of breath, right? Feverish, usually a non-productive cough, right? So events leading up to it. Hey, have you been coughing anything up? No. Have you been coughing? Yes. Okay. So non-productive cough, fever, tachypnea. So pneumonia. You listen to lung sounds with pneumonia, the only place you should hear any junk is where that pneumonia is. So right lower lobe pneumonia, you hear some crackles and rhonchi, junk, maybe even a little wheezing in that right lower lobe. Everything else should be nice and clear though, okay? Supportive treatment. If you hear wheezing, nebs, epiglottitis, scary. I was always respectful of it. Always, hey, it's bad and it can get bad. But one day we were taking care of a kid with epiglottitis in the ER, and the ER doc had the anesthesiologist come up to be safe. And that triggered my warning lights a little bit. And then I was listening to, remember, I've been respectful of it and I know it's bad, but then I sat there and I listened to this ER doc I respected and this anesthesiologist I respected, and they were both like shitting themselves. And I went, wow, I don't respect this quite enough. Apparently, I'm not scared enough of this. Okay, so it taught me a whole new respect for this. Epiglottitis, bacterial, epiglottis swells, right? So the epiglottis opens to allow air in and out, closes to protect. Well, it's a leaf shape. It's just, I mean, it's shaped kind of like this. Now picture it swelling up and becoming an acorn in their throat, right? And if it spasms worse, or it's got swelling, if you cause it to spasm, it can completely close off that airway. And then you guys start making cuts in the kid's throat. You can't. I certainly don't want to. And obviously this anesthesiologist who makes his $500,000 a year dealing with airways, he didn't want to either. Okay, so big rule with this. Treat them gently. Transport them gently. You want the lights and sirens on and you want to be doing about 1,000 miles an hour to the ER. Don't do it. Turn the lights off. Gentle, easy transport. Don't have the kid bouncing in his car seat, getting upset and scared and trying to scream, right? Don't put anything in his mouth, right? We all want to let the kid suck on a binky, but if you do this, you stick your finger only that far into the back of your tongue, you can touch your epiglottis. So yeah, the binky's only this big, but their airway's tiny, right? That you could hit that epiglottis. You can look in the mirror. If you take a tongue depressor or a butter knife, whatever, right, and you flatten your tongue out and go ah, and flatten your tongue out, you can see the tip of your epiglottis in the back of your throat. Okay, you don't want to hit that. You know, the kid's got croup and you want to give him a popsicle. Great idea. It's going to make his throat feel better. Kid's got epiglottitis and you happen to touch that epiglottis, it could spasm and kill the kid. Now, so what do we see for symptoms of this? These kids get super sick fast. And by super sick, they look like crap. They spike a huge fever and it comes on in a really short period of time. And their throat hurts, like to the point where they drool. They will literally, it's basically tripoding, and they'll just stick their chin out and just let the drool run down their face. Because every time they swallow, it moves the larynx and it moves the epiglottis, and that hurts, so they won't do it. They'll just drool. Croup versus epiglottitis. Croup comes on slowly in comparison. It might come on over a day or two, maybe even 3. You know, they just don't feel very good for a couple of days. And then tonight they start with the barking and a fever. Croup. They feel good, and in a matter of a couple of hours spike this huge fever and feel like shit. And you hear stridor and they're drooling. Now you might hear this croupy bark with epiglottitis. That's very possible. But the difference is speed of onset, how fast the fever comes on, and the drooling. With croup, they'll swallow. Okay? Epiglottitis, they're not going to swallow. Strangers. When we walk in a room, the kid should try to hide from us. You know, he's sitting on mom's lap. He should turn his head away from us. He should look at us and then go, and try to hide. Or he's standing on the couch next to his mom. It's super common for them to like bury their face behind their mom's shoulder, right? Oh, you can't see me, I'm hiding, right? You're in Walmart. I do this all the time. I'm walking along and mom's pushing this little baby and a kid in a baby carriage or whatever in a shopping cart, and I wave at the kiddo and smile, or I make a face at him, and you know, and some of them smiling back, and others get shy and try to hide. Okay, but if mom walked away from that shopping cart to go 2 aisles over to grab something, and I was standing there making faces, the kid's going to start screaming. I mean, that's normal. Okay, if we walk in the room and that kid just doesn't give a shit that we're there, that apathy towards us, that concerns me. Okay, I've been telling you guys since day one that I don't like pet names, right? I like sir and ma'am when I address people. You know, I like to shake hands, you know, even in COVID, right? Shake hands. With a little kid, I will break this rule in that I will call a 3 or 4-year-old buddy or honey or sweetie, right? And the other thing I do is I get down to their level. You know, if you stand up there and you tower over this kid, you just intimidate him. If he's sitting on mom's lap at a kitchen chair, I'll sit in the chair next to them. And that way, unless, typically the kid's going to be a little bit higher than I am looking down at me, especially if he's standing on mom's lap. And then I just, if they're old enough, I'll stick my fist out for a fist bump and say, hey, how you doing? And I try, if, from the door, right, I do that assessment. And with the kids, it's that triangle we'll talk about. If I look at the kid and the kid looks good, my first goal with this kid is to make friends with him. Because if I make friends with him, he's going to be easier to assess. He's going to be easier to treat. If I walk in and scare the crap out of him, it's just going to be a nightmare of screaming and yelling. And I don't want him scared of me. The other thing is, remember that when you walk in that door, everything that happens to him for the next 6 hours to 5 days, however long he's at the hospital, he is going to relate them to you. So if you walk in and you lie to this kid, or you walk in and you scare him, everybody after him is either going to be scary or he's not going to trust them. So set the tone right from the beginning, that, hey, let's be friends. Let's be buddies if we can, okay? School-age kids, 6 through 12, they're starting to look more like adults, right? The heads are more in proportion to the rest of the body. The skin is more in proportion to the rest of the body. And they are starting to be peer-driven, right? Whether it be their friends at school or a favorite uncle or, whatever, grandparent, parents as well. They want praise. They want to be accepted. They don't want to be scolded or whatever. That goes with us too, right? We can really, like I said, be friends with them. They start to understand all of these things, right? They've had friends get sick, parents and grandparents get sick, parents and grandparents and family members and friends and whatnot die. And they need help, with being scared of things. At 3 years old, you walk in a house, this kid might be running around the house buck naked and not care that you're there. 9-year-old, it's a little different, okay? So when we have to do things that expose parts of their bodies, we might do it 5 times a day to other people. This kid never has it done to him. So, try to keep them covered up, allow for some modesty and privacy, tell them before you're going to do anything. The same goes whether it's a 9-year-old or a 90-year-old, right? And be respectful. 12 to 18, vital signs are pretty much normal. Males, actually, physically, I read a study, I think it was a year ago, that said most females are basically physically done growing around 16, 17. Males will frequently have one last kind of growth spurt in their early 20s. But they're still adult size, adult features, adult vitals. That whole privacy thing is still important to them. Okay. They may take pictures of naughtiness and send it to their friends and post it on the internet, but that's them. We still need to think of them as being pure and innocent and shy. So same thing. I need to do this. Keep them covered up, right? Okay. Ask for their help. That's the other thing I'd love to do with kids is I ask them for their help to do things, right? I might be assessing this might be a 5-year-old and I'm doing something with their 6-year-old sister, if there's something that this 5-year-old can do, like, hey, we need shoes for this little girl. Hey, buddy, can you go get her sneakers? Yeah, yeah, yeah. And they love that. Okay. Same thing with older kids too. You know, I like to involve them and, you know, treat them as adults. Think back, some of you, it's far easier than it is for me, but think back to when you were 16, you absolutely knew which adults around you were assholes, right? Which ones you didn't trust, which ones were banging the neighbors' wives. I mean, kids are observant. I say kids, I mean, you know, I certainly didn't think I was a kid at 16. If I knew everything at 16, you know, oh, Jesus. Anyways, but treat them as adults, treat them respectfully. You don't have to call them ma'am and sir, but, you know, name, hey, I'm Kevin, what do you like to be called? You know, I don't expect a 15-year-old patient to call me Mr. Jenks. You know, I don't. My name's Kevin, all right? At this age, they're starting to, well, 12 to 18, they're either entering through the middle disaster years of it or coming out the far side of puberty, right? People go, oh, I'd love to be in high school again. Screw that. Not me. Nope. This was way too confusing, way too anxiety ridden, and way too embarrassing. No, I'm done with it. That's their life. This is their day-to-day life, okay? Now, legal capability for decision making. Yes and no. Until you are, the day you turn 18 in most states, you're not supposed to be able to legally make decisions unless a few things happen. If you are married, your parents have already signed a thing saying you can marry somebody. You are now considered an adult legally. If your parents have signed you off to the military, right, at 17, you can join the military with parental permission. You are considered an adult at this point. If a court has judged you to be your own person, okay, then, you know, you've moved out, complete irreconcilable differences with parents. It's a disaster at home, and you've proven that you can take care of yourself. You know, judges will accept that. It's rare, but it's out there, okay? Other than that, we need some sort of adult input on what we do with these kids. That being said, we still have, obviously, implied consent, right? 17-year-old, and you can't get hold of the parents, and you know this kid needs a nebulizer, implied consent. Let's give the kid a neb, okay? Oh, he needs an EpiPen, implied consent. Hit him with the EpiPen. If we can't get hold of the parents, I'm going to give this kid a few options in his care. You know, hey, listen, legally, I have to take you into the hospital. You've been in a car accident. I can't get hold of your parents. There's nobody else around who'll sign for you. Like, if I get a 16-year-old kid and his 21-year-old sister shows up and she's willing to take responsibility for him, I'm gonna say okay. But otherwise, all right, dude, listen, we are here. We're in on the Raymond Eppingtown line. You've been in a car accident. I know you don't have anything that hurts. I got to take you. It's the law. I'll give you a choice. You want to go to Exeter, or you want to go to Manchester, right? Oh, my mom works in Manchester. All right, we'll go there. All right, so I'll give him, you know, some choices. Brain has not yet developed adult judgment. No, no, seriously, I didn't know that. Right here, hold my beer. And we know that a lot of guys, their brain does not develop that adult judgment until we're well into our 30s or 40s. And then we have another slip when we're about 50. We start trading 50-year-old wives in for 25s. Judgment just goes completely out the window again, okay? Emotions get handled differently. And again, this is not cut and dry by age. This, you know, this kid handles things better than this kid and vice versa, right? They're invulnerable, right? Will live forever. This is why the infantry around the world of all armies, Marine Corps, and navies are full of 18 and 19-year-olds, because I'm invincible. Okay, take that hill. Yes, sir. right? You ask me to charge a hill, I'm going to go, I don't think so, Tim, right? I'm smarter than that. I know, but not, these kids don't, right? Hold my beer. Risky behaviors. They start to have problems with depression and suicide. Now, we see, oh my God, we see school-age kids with depression. We see school-age kids with suicidal ideations. It's rare. It starts to get more common. Oh yeah, because let's see, let's go back here to this slide, puberty, and the fact that these kids, males and females, are having trouble wrapping their hands around these changes in their hormones. I mean, hormonal changes are, holy crap, right? And they've got all these social pressures on them, and girlfriends and boyfriends leave them, and it's the end of the world, and they got problems at home, and we start to see a lot more of this at this age group. So a kiddo, anybody, but you know, a kid makes a comment like that, you got to take it seriously. You know, I remember, God, I think he was 14. Mom left the house for like 10 minutes to go around the corner, and she came back and he put his belt around his neck, closed it in the freezer door, and sat down. You know, so hanging is kind of common. I've seen a bunch of them with these kids, and unfortunately they do it where other people can find them, which, I mean, it's good because they don't like go lost forever, but it's not the people you want to find them. So then around that you have, you know, the whole school gets affected, you know, so it's ugly. We do treat them physically with medicines and with therapies, more like adults, right? So in the state of New Hampshire, our protocol is, if they fit, so we've got this thing called a Broslow tape, or a weight-based tape. We can take this tape and set it down next to the kid, one end at the foot and the other end at the head, and you look and, okay, so they're this long, and at that length, the color is, let's say, white. So they're roughly 12 kilos. We want this much epinephrine for cardiac arrest. We want this much epinephrine in anaphylaxis. We want to use this size oral airway, this size BVM, etc. But the state protocol says when they no longer fit on that Broslow, we treat them as an adult. That Broslow is good to about the age of 8 for your average 8-year-old. So over 8 years old, we are treating these kids basically as adults as far as medicine goes. Psychosocial differences, you know, school-age kids. Oh, so here, 12 to 18, think about this one. We're lumping these kids into one bracket. But they're different enough that it's illegal for an 18-year-old to date a 16-year-old, right? Because they're that different. But we're putting 12s and 18s together. You know, so keep in mind that that is a huge range, and you're going to have a lot of different looks, thoughts, outlooks, everything, but in that same age group. Neonates. Remember, was it last week? Yeah, I had that slide up that showed when the egg is released from the ovary and it goes into the fallopian tube, and it, like, what is it, one day it doubles in cells, and then it doubles again and doubles again and double, right? It's just it's growing exponentially. That continues through, you know, that kind of infant toddler size. They're just, I mean, kids have growth spurts, but those first couple of years are mind-blowing in how they grow and develop compared to 15 years old, you know. Size up, scene size up is the same. You know, as I approach, what do I see, hear, and smell? What's my scene size up? Is the scene safe for me, for them, for bystanders? All that remains the same. Some of our equipment, we need to have different size equipment for different size patients. In the hospitals, you will find a Broslow cart, and it's based on that Broslow tape. And the drawers are different colors. So you have white, pink, blue, whatever, red, whatever the colors are. I can't think of them off the top of my head, but this kit is white on the chart. You open the white drawer, everything you need is in there in the right size. Think about those of you who are on fire departments and rescues right now and EMS. What do you guys have? Nothing. We have a pediatric blood pressure cuff. We have a baggie, a Ziploc baggie with 7 different oral airways and another one with 8 different nasal airways. Well, which one's the right size? I don't know. I'd have to size it. You know, it's quicker, especially in the heat of the moment with a kid. If we all had these Broslow kits, but we don't. We're having this fight at action. Why don't we? They don't want to spend the money. Well, if we have one bag that has everything in it, it's cheaper than one bag with all adult stuff and a second bag with 8 different sets of pediatric things. It's cheaper. So that's what's more important. No, it's not. You know, when you get into that 3-year-old who's not breathing and shit goes flying because there's 3 of you digging in this bag and now you can't find anything you want, it's not good. So if you have anything to say in your department, you want to pick one fight, this is the fight. Okay, let's have a pediatric bag based on sizes, you know. So the Broslow tape. Now the thing to think about with the Broslow, I researched this, I don't know, 8 or 10 years ago. I was looking for a new Broslow tape and I was having trouble finding one. But what I did find was a study done in Europe, and it was done by a group of anesthesiologists and intensivists, ICU docs. And it's a union of these guys, you know, so it's not like 5 of them, it's all of them in Europe. They said that they don't like them because it's an average. When you take this tape that's this long for this kid, it doesn't take into account whether he's this big around or this big around. So half the kids were underdosing, half were overdosing. So that sticks in my head. I take this tape out and I look and I go, oh, it's white. It's a fat kid. I'm going to go a little bit, like maybe one size bigger. Okay? Especially for drug dosages. So keep that in mind. Pediatric stethoscope. Our stethoscopes for adults are yay big around. You might take up half the kid's chest with it, right? So we want the proper size scopes. Blood pressure cuffs. If the cuff is too big, it will give you a false low blood pressure. If it's too small, it will give you a false high. We need the right size cuffs. Pulse oximeters. You got to remember, when we talked about this a year, 2, 3 years ago, whatever it was, back in September, we talked about respiratory stuff. Pulse oximetry is a sensor that goes down through the finger. The regular pulse oximeter has 2 beams of infrared light. How much of that gets through gives you the number. So if all of that light gets blocked, it tells you that the hemoglobin is 100% saturated. That's for an adult-sized finger. Take a finger that's 10% the size of mine, and that light's going to get around it, and it's going to give you false low readings, okay? Or it's not going to give you a reading at all. So we need appropriate sized equipment. Airways, masks, BVMs. state of New Hampshire requires us, and I think this is wonderful, to have a neonate bag, an infant bag, a pediatric bag, and an adult bag valve mask. Where are they? They're in the cabinet, right? Most of the ambulance services I've worked for, you keep a pediatric and an adult. Great. I need the neonate. We just delivered this kid. Now somebody's got to leave, right? There's only 2 of you, and you know things are so smooth at this point that we're going to bag a kid that one of us can go out to the friggin' ambulance and dig through cabinets looking for the neonate bag. It's horse shit. Okay, I'm gonna try to climb off my soapbox before I fall. The problem is, at one point, there was a national movement to do away with everything but pediatric and adult bags because there's too much stuff to carry already, and we can give little puffs with a pediatric bag. Not when your adrenaline is freaking flying and you go and you pop the kid's lung, right? So appropriate size bags help prevent barotrauma. Cervical collars. You know, we have an adult, like most of us carry this stiff neck, whether it's stiff neck or a generic version, and it's got 4 adjustable, you know, heights on it for adults. We need the same thing for kids too. And then good luck keeping it on the kid, right? Sometimes it's a towel rolled up and wrapped around the neck like a horse collar. Works just as well, and they're more comfortable, and they'll let you leave it on them. Bulb syringe. Oh, because remember, for those little kiddos, I said we really shouldn't be using battery suction, right? We should be using bulb syringes. Blankets. This 60 GTTS is drops. 60 drops per ml IV tubing, also known as micro drop tubing. Because if we're going to start IVs on little kids, which we can as AEMTs, we need to do a couple of things a little different. 1, small IV bags, no bigger than a 250 ml bag. Okay, adults, yeah, hang a liter bag. That's awesome because most adults can take an extra liter of fluid on any given day and do no harm. Most of us on any given day would benefit from a liter of fluid, because chronically we're dehydrated, okay? But you give a liter of fluid by accident to a kid who has 12 ounces of blood in his body, you will put him into congestive heart failure fast. It's 250 ml bags. An infant, I might even just use a 100 ml bag. And then I'm gonna use the 60 drop set. Because if the problem is, if you take that 250 bag and you run it in wide open through a 10 drop set, that 250 could put them into failure. But if you run that 250 in 10 times slower with a micro drop, 6 times slower with a micro drip, you won't put them in failure. So, and the other thing is, if you happen to forget, like I want to give them a bolus, I want to give them a 250 ml bolus. If you forget with a 60 drop set, by the time you look up, you probably still don't have 250 in yet. It's that much slower. But if you forget with a 10 drop set, you look up and you've run 500 into them. Oh crap. Okay. Now this volumetric IV device is called a Bureautrol. That's one of the brands. That is a IV drop set that you can pre-fill the amount you want in it for your bolus. So let's say I want to give I'm going to give 20, this is a typical bolus for a kid, not just 250, but 20 milliliters per kilo. So let's say this kid weighs 10 kilos, 22 pounds. I want to give him 10 times 20, that's 200. I can fill up to 200 in this big drip chamber, and it will run out of that drip chamber. And when that's empty, it won't take any more out of the bag. So it's a safety measure. I don't even know if they're allowed in New Hampshire. They want us running fluid through pumps on these kids. Not an AEMT skill, mind you, but you've got to be really careful. So a 60 ml drop set on a kid, a little kid. You know, you got that 14-year-old who's been hit by the car. Okay, we're going to use regular size tubing on him. We need smaller catheters. Kind of. 22 and 24 gauge catheters are super small, super thin. They bend really easily. So like when you're trying to advance a 24, one of the problems I have with them is having them kink as it's going in. And so now it's sitting in the vein, bent over, kinked over, and it won't flow. And when you go to pull it out, it's like a fish hook. The other problem with the 22 and a 24 is it's so small that when you stick it into the skin, into the vein, you know, you're looking for flash, right? That needle is so small that by the time you get flash, you're usually through the other side of the vein. So when you're using a 22 or a 24, you have to go really slow into the vein, or while you look for the vein. Of a 4-year-old who's fighting, kicking, and screaming, yeah, I hate him.
Kevin,
yeah.
What's the size usually of a pediatric butterfly?
Oh, those are like, butterflies are like 27 gauge. They're tiny. They're basically the same size as they use to draw bloods, and it takes forever to push anything through them fluid-wise. I put an 18 gauge into a 3-hour-old kid once. Okay, so I mean, I bent his wrist back, and in the little fold of fat in his wrist, I saw a nice big vein. Okay, so look for a good vein and put the largest size you think you can put in it. 22s and 24s are really common in these little kids, though. Now, remember, national standards are adults get D50 for hypoglycemia as an AEMT, children get D25, and infants get D10. In the state of New Hampshire, we use D10 for everybody, okay, because we want to give that sugar slower. We don't want to just pound it into them like we talked about. We need pediatric size splints. Sagers come in a PD size. You know, you guys were playing with those Velcro ones last night. That arm one for an adult, that'll work as a leg for a kid. Okay, they're double use. You could use a SAM splint on a tib fib for a 1-year-old, but you're not going to, you know, that's not going to work so well on me. Okay, so you need the appropriate size splints, and then you need appropriate size car seats. In the state of New Hampshire, you have to have a car seat capable from neonate to, I think it's 8 years old. So basically a booster seat conversion. It's not easy. I mean, these seats take up a lot of space in our trucks, right? But we need to be able to transport them safely. Do not allow the fact that you're going to a kid call distract you, okay? And recognize the differences that you're going to see trauma-wise because of everything we've talked about so far. All right, to this point, do you have any questions? All right, tell you what,
Evan,
yeah.
Can you go over like what if we saw pneumonia and bronchiolitis on a test, like what would be the decipher between picking the two again?
I know we're going to see these again later, but you know, it's a good question. We'll go into it right now too. So like bronchiolitis, think bronchitis and pneumonia. Okay, so in an adult, bronchitis, lung sounds are generally junky, kind of all over the place because of mucus, right? So crackle, rhonchi, you might hear some crackles, and you'll typically hear some wheezing. And they're generally coughing up stuff like yellow, green, brown sputum. They may or may not have a fever. Pneumonia, short of breath, generally have a fever, generally are not coughing things up. They're coughing, they have a cough, but they're not coughing anything up, so it's non-productive cough. And when you listen to lung sounds, you hear junk in one area, whereas with bronchitis, you hear it everywhere. So once you can picture that in your mind with an adult, now think pneumonia, bronchiolitis. Bronchiolitis and bronchitis are basically the same exact thing. It's just one's in an infant or toddler and one's an adult. Okay, they may not be coughing stuff up. They're coughing and coughing, but they're probably swallowing it. And they're not going to be able to, like you ask this kid, a 3-year-old, what are you coughing up? They don't, but those are basically the differences between the two. Does that help?
Yeah, thank you.
You're welcome. All right, so I was looking at break. We're 20 slides into 120. So obviously I've rambled a little bit, but as we move forward through the rest of these slides, there may be some things we've already covered, and so I may not go into them as deep. But if I skip over something that you want me to go a little deeper into again, or still, or whatever, please let me know, okay? So scene size up, look at the surroundings around the kids. Are they being cared for? Are they being neglected? Are they being abused? Try not to separate parents from the kids. We talked a little bit about this last night with our arrest scenario. Kids do better with mom and dad, and moms and dads do better with their kids, right? And having the parents participate, like hold the mask for blow by, is going to go a lot better than us trying to hold the mask in front of the kid. Sometimes we're there because of abuse or neglect, and sometimes we pick up on it. If you think there's abuse or neglect going on, you have to call Health and Human Services and report it. Just telling the ER nurse is not enough. It's actually a misdemeanor if you don't do that yourself. So some things to look for. The parents don't let the kid answer. All right. And then the story that you're getting does not match what you're seeing. Lots of bruises. Now, keep in mind, bruises of various ages. Keep in mind that 4- and 5-year-old kids, they get bruised. They run, they fall, they trip. They're not the world's most coordinated little people at this point. So that's not in itself, if it matches the story, if it matches, okay, well, that's not unusual. It is better, though, to report somebody out of goodwill and be wrong than to just assume it's normal and not report it. Soft areas. So remember, shins especially. Shins they run into stuff all the time. But soft areas, cheeks, butts, bellies, okay? The kid is scared to death of everything, right? Wound patterns. So kids run into stuff and have bruises. Kids do not run into hairbrushes and have, 7 rows of 30 pinpoint bruises. They do not run into hot irons. They do not run into, they don't run into bats and belts and, sticks. I mean, they run into sticks, but they don't have nice, long, perfectly cylindrical bruises from a stick. Bite marks, burn marks. Yes, kids pull, kids reach up and pull hot pans off the stove. Spaghetti sauce, oh, that's a brutal one. But they don't run into cigarette butts. Can they? Sure, they can walk past, run into dad, whatever, but they do it once. They don't have patterns of cigarette burns, okay? Neglect, right? Are they being supervised adequately, or are they just being cut loose? The 5-year-old's running the neighborhood and nobody knows where the kid is, okay? Injuries to the genitals. And this one is this one is awful, but like that whole female castration thing, right? Where the extreme Muslim communities, cut off female external genitalia. God. Untreated illnesses. Now, when you take into account religious beliefs and things like leaving vaccines out of it for now, but like blood products, some of these organized religions, you can't do blood products. So that's different than just ignoring the fact that the kid's got bronchitis and he's not being treated for it, okay? If the kid has a broken arm and it's obvious from the bruising that it's been a couple of days and they haven't sought help for it, that's a red flag. Malnourishment. If this kid is 9 years old and knows things about the birds and bees that he shouldn't, there's probably a reason for it. An unsafe living environment. Okay, so a couple of things that I've seen, a babysitter threw a scalding hot towel on the kid to try to make it stop crying. Didn't work real well. The kid got intubated because he had airway burns, 6-month-old. Kid handcuffed to a hot water pipe. You know, the hot water pipes for the heaters. Mom handcuffed him to it and left the house for a couple of hours. She went to jail, and a year and a half later, she got out, and the very next day got arrested because, she went to do laundry and handcuffed him to the bumper of her fucking truck. Slow learner. Anyways. So things that just, they're not safe, right? The living environment's not safe, whether it be trash or broken steps or no heat, no air, whatever, okay? Now, assessing them, the pediatric assessment triangle. I love this. I mean, I basically use this for adults too, right? I've talked to you guys a lot about from the door, what do I see, hear, and smell? That's what this is, right? What do I see? Their appearance. Are they sitting up? Are they holding themselves upright? Are they making eye contact? Are they slumped over, limp in mom's arms? Work of breathing. Do they look like they're acutely short of breath, right? Are they gasping for air? Are they tripoding? Are they grunting? Are they seesaw breathing? All of those things. Circulation to the skin. What color is he? You know, is he pink, warm, dry? Is he cyanotic, pale, sweaty? Okay. So these are basically your mental status and ABCs, right? What do I see, hear, and smell? And we're going to go back into those as we go, but all of that starts with your scene size up, just like with adult calls. So one of my paramedic instructors told me, if you think you should do something, you probably should. If you just think, maybe, that's your subconscious saying you're seeing something dumbass that you don't recognize. So like, should I report this? Yup. Should I bag this kid? Yup. Okay, so it works in a lot of ways, not just should I start an IV? Should I bag the kid? Should I report this? Yes. Okay. Now SIDS, we talked a lot about this last night, right? It is a diagnosis of exclusion. When they don't know what caused it, they'll call it sudden infant death syndrome. So whether you think it's SIDS or whether you think it's abuse or neglect, document everything about the scene from the time you walked in the door to what your assessment was, why you decided to do or not do any treatment or resuscitation, how the parents or caregivers were responding before you made your decision, after you made your decision, when you told them you had to have the police are on the way to come give us a hand with this or whatever it is, okay? Document everything. And then general impression. And what we found with that, if you want to document your assessment and your impression as The pediatric assessment triangle was work of breathing, appearance, circulation of skin. You can do that if you want, okay? I still document it the same way, that I showed you back a couple months ago. I mean, using chart, but I'm going to use maybe a little different terminology with the kid. Like from the door, his work of breathing appeared, from the door, okay? Appearance, muscle tone. An infant at 2 months is not going to hold himself up. So that's appropriate. But he can hold his hands and arms up, right? When they come out of mom kicking and screaming and thrashing their hands versus limp like a wet noodle, okay? How are they interacting with parents? How are they interacting with us? If they're being shy towards us and hiding behind mom's shoulder, that's normal, okay? If they're scared of the parents and they want to be with us, that's not normal, okay? Consolability, the kid's crying, sobbing. Can mom make that better? Because that's usually what happens, all right? Mom can usually knows how to make the kid, feel better and not be inconsolable. Do they make eye contact? Now, kids won't generally sit there and, try to stare you down, but just, will they look at you or look at mom when you talk or when mom talks, right? A lot of times the kid's going to follow this conversation like a tennis match. Perfect. That's what we want. Do they have their appropriate speech for that point in their lives? And you can ask mom, hey, mom, is he talking yet? Yes. How is his speech right now? Okay. So appearance, work of breathing. What do I see, hear, and smell, right? Do I see good airway, good air rise and fall, chest rise and fall? Do I see seesaw breathing? Do I hear any sort of airway noise, right? Do I see any sort of retractions? Now, nasal flaring is a very good tool to look for, or it's a very good assessment piece. Remember, kids are nose breathers. So when they are having trouble breathing, instead of opening their mouth and going, they will still try to breathe through their nose. Their nasopharynx and their nares are a lot smaller than the mouth. So their nostrils will actually kind of open up like little piggy nostrils or like trumpets and get kind of big, and they'll flare to try to pull more air in. And then circulation of the skin, color, temp, moisture, pink, pale, cyanotic, flush, warm, cold, cool, dry, diaphoretic, okay? Primary assessment though, so that's your general impression from the door. We still are gonna do a primary assessment, and that may very well be going, hey dude, and doing a fist bump and talking to the kid like I do to adults. You walk in and that kid looks limp and looks unresponsive, we're gonna go CAB just like with an adult, compressions, airway, breathing, right? Check her pulse, no pulse, start compressions. 2 minutes, airway, breathing, compressions. 2 minutes, airway, breathing, compressions, all right? Don't delay any more than 10 seconds. Now, we talk about radial pulses with adults. With infants, check, instead of a radial, check for a brachial pulse. Now, brachial pulse, you feel inside your elbow. On the inner, probably third of your elbow, on yourself, you should be able to feel your brachial artery and a brachial pulse. That pulse runs up the inside of the bicep, between the bicep and the humerus. It's the easiest pulse to find on an infant, because a lot of these infants have chubby little hands and chubby little wrists, and it's a very small artery down there. So brachial's easier. They also have chubby little necks, so brachials are easier on a little kiddo. As far as CPR for kids 1 to 8 years and infants, so basically from birth to about 8 years old, it's 2-person, 30 to 2, just like an adult. However, we will use 15 to 2 with 2 rescuers. Part of that is it's a smaller person we're working on. We don't have as much room, like for an infant, we can do 15 to 2 with 2 people, and I can do thumbs with my head way out over his feet, and you're ventilating him, and we're not banging heads. That's kind of the way I look at it. But also the other thing is that kids are generally respiratory arrest, cardiac arrest in nature. So they've gone into cardiac arrest with respiratory failure, so they need a few more ventilations than they do compressions. So we're going to ventilate them twice as much. Excuse me. I'm either dehydrated or I just love the grape cranberry juice. Probably I love grape cranberry juice. I especially like it with a little whiskey in it, but that's for later, not while I'm with you guys. All right, now, hand position. With children, you can use two hands. We used to teach just one hand, but if you can't do that effectively, you can do two hands, same positioning, lower half of the sternum, and you want to go 2 inches or 1/3 the depth of their chest wall. And you got to do at least 100 a minute. And with infants, at least 100 a minute. And you're either going to do, if you're doing one person CPR, you're beside them with 2 fingers on the sternum, so you can do, 30, 2 puffs, and you're right there. You're not wasting time moving around them, okay? 2 rescuers, 2 thumbs encircling the body, okay? And 15 to 2. And you're going 1.5 inches, basically 1/3 the diameter again. Cardiac arrest, as I've said, hypoxia, and then the secondary reasons are hypovolemia, whether it be trauma or dehydration. And yes, dehydrated kids can go into cardiac arrest, okay? If they're responsive or unresponsive, right? What's their breathing, right? If the kid's unresponsive and breathing, ABCs. If he's responsive, ABCs. This is a great picture that shows that blanket or towel under his torso. So it's not just across his shoulders. You can see it's like his entire back. And you can see the difference in his airway without it. This kid's got a giant head for the rest of his body. And if you look right here on this kiddo, that is a jugular vein, but it's not JVD, okay? To see a jugular vein on somebody lying flat is not unusual. It looks just like the vein on the back of your hand would, right? When that thing is engorged, it looks like a fire hose or a garden hose. Or you look at it and you're like, is that a vein or a muscle? And you push on it and it feels soft, then that's a jugular vein. That would be JVD. But just to see jugular veins like this, not unusual. You sit this kid up more than, say, 45 degrees, that's probably going to go away. JVD doesn't. JVD you're going to see sitting up as well. Airway, no difference, right? Is it open? Will it stay open? If not, I got to do something for it. Padding under the torso, and also the fact that if you hyperextend the neck too far, you'll actually take that airway and make it harder to ventilate going in the opposite direction. Right, so something under the torso, nice, just that sniffing position, right? As you're walking into the house sniffing for cookies, that's the position for his airway. And, is he breathing? Is it adequate? Yes or no? Will it stay adequate? Yes or no? So does he need a little oxygen, a lot of oxygen, or do I need to bag this kid? If the kid is having trouble breathing, do something. Put him on some oxygen. Non-rebreather's fine. Cannula's okay. Blow-by's okay. Non-rebreather's great. But if they're having trouble breathing, do something to prevent this from getting worse. Does that make sense? So here's a, why is this guy holding a cup in front of him? Well, so this is one of these old school things where if you put a oxygen supply tubing into a paper cup.
Down.
All right, who's making all that noise? Who is that? Alex H. Your people in the background are making a ton of noise. So the thing is that a cup is not threatening to this little kid, right? So they put the oxygen supply tubing, they cut a hole in the bottom of the cup, put it in the cup, and the kid will chew on the cup and whatnot. That's fine. Some of the books, I don't remember if they still do it up. Don't use a styrofoam cup because he'll chew on that and choke on it. Well, no shit. Anyways, maybe a cup is okay. Most of the time you let mom hold that mask and the kid's going to be fine with it. If mom's holding the mask, it's okay. And the kid might want to chew on the mask. That's okay. All right. But from the door, does this kid need oxygen? No. I mean, granted, we haven't done an assessment on him, but from the door, he's holding himself up. He's pink. He looks happy. He does not look in distress. So it's a great video. I mean, it's a great picture to show an example of blow-by on a healthy kid. Yeah. Whoops. Come on. There we go. Now, again, they may not let you do a cannula or a mask. It may have to be blow-by, and that's okay. You just run it at 15 liters and put it under so that it's coming up in front of the kid's face. Don't forget, again, small volume equals fast shock. Hemorrhage control. As you know, like I said, 12 ounces of blood is a lot less than my 5 liters. So you've got to be even more aggressive with hemorrhage control, like that scalp laceration. Oh, it's just a scalp. Oh, it's just 40% of his blood loss in shock. Okay. Make sure you keep him warm. What are some of the signs of hypoperfusion in this kiddo?
Sunken fontanelles.
Yeah, sunken fontanelles, very good.
Skin color,
Yeah,
cyanotic.
Pupils.
pupils. That would be kind of a late sign, I think. How about heart rate?
Slow cap refill.
So slow cap refill, yep. Heart rate, you should see. So initially, you'll see heart rate climb just like with adults. But as kids fail, their heart rate drops. So if you've been seeing, like in respiratory distress or shock, you've been seeing 100, 110, 110, 120, 130, 130, 140, and then all of a sudden you see 80, we're in trouble, okay? Because it will now go 80, 60, 40, all right? Yeah, those are the good ones. Secondary assessment, assess the thing that hurts them last. If they've got a boo-boo ankle and you grab onto the ankle first and it makes it hurt more, they're not going to let you touch anything else. So, they've got a hurt ankle or a hurt lower leg. I'm going to start at the head and, work my way down. That ankle's the last thing I'm going to touch. I like to use language for the appropriate audience. So for me to say boo-boo to a 50-year-old male is insulting and he should kick me right in the junk. But for me to say boo-boo to a 3-year-old male, it makes perfect sense, right? You don't want to say to a 6-year-old, I'm going to palpate your abdomen. I want you to tell me if there's any rebound tenderness. You might as well look at the kid and recite shit in Greek to him, okay? But if you go, all right, buddy, so at this point, I gotta be real gentle, but I just gotta poke on your belly for a minute. Tell me if your belly hurts, okay? Now, when I push in, does it hurt? No. All right, when I let off, okay, did that hurt more? Or was there, so use appropriate language. Past medical history. If the kid's alone, you're probably not going to get any. Sample history, you can ask kids this. You'd be amazed at, 5-year-olds get stories to tell. You ask them about lunch, they'll tell you all kinds of stories about lunch. He can tell you what he ate. All right. These kids who are on medicines every day for stuff, they usually can tell you. They may not always know the full name for it, but they might know why they take it. So do you take any medicine every day? And they can tell you. Certainly a 2-year-old's not, but you'd be surprised at what some of these kids can tell you. What were you doing when it started? Now, this can get hard because they don't want to get in trouble, right? Mom tells you, well, he crashed his bike, he fell off his bicycle. And you're looking at the injury and you're like, this just doesn't fit. Hey, Mom, how about you go get him a pair of clean shorts, a clean t-shirt, because he's covered in grass and shit, right? And his sneakers. And while Mom's out of the room, all right, dude, your mom's not here. Did you really fall off your bicycle? Oh, I fell out of the tree. Okay. I'll tell the kids too, and I've had people tell me this is wrong. Look, I know you didn't fall off the bicycle, dude. I need to know what happened. I'm not going to tell your mom. And it's true, I'm not. Oh, the doctor will, or the nurse will, but I'm still the good guy. But I also found out what happened for everybody else. And people go, oh, you got to tell the parents. No, I don't. What I got to do is gain this kid's trust. I've got to get a good history, and I've got to find out the truth about what happened. Because if the kid's scared to death to say, I rode my bicycle out in front of a car, like the guy that hit me once, and he and I both agreed, no harm, no foul, and we both went our different ways because we were both scared of getting in trouble. Okay? So I don't know. I will do that. Action Office is calling me. That can't be good. I'm scheduled to work tomorrow. I'm not answering. All right. So, where was I? Oh, so I may not, like I said, the doctor will tell Mom at some point, but I'm not. I want to know what happened. So what were you doing when it happened, right? What time? Does the pain go anyplace? All the same questions. Now, Mom, is this his normal activity, right? I don't remember. My youngest is 24 years old. I don't remember specifically how old they were when they started to hold themselves up or stand up or walk, right? So, Mom, is he normally able to hold himself up at this point? No. Okay, cool. He can't stand up right now. Is that normal, right? Events leading up to it, right? How's he been feeling for the last couple of days or a week? Has he had a rash? Has he been drinking his normal bottles, right? And how many diapers has he gone through? Right, normally, how many diapers does he go through in a day? Don't ask Dad that. Dad can't tell you. We don't know these things. We don't know shit like that. But Mom can say, oh, he goes through 5 diapers a day, or he goes through 5 by lunchtime, and he only uses 2.
Speak for yourself, Kevin. Speak for yourself.
Whatever. Typical guy stuff. So, he goes through 2 between lunch and dinner, and there's 1 more at bedtime, and dads are like, I change him when he's wet, right? So, all right. So he normally goes through 9 a day. How many's he gone through? 4. Have they been soaked? No. All right, the kid's dehydrated. Any diarrhea, vomiting? Do you have any medical problems? Ooh. So with little kids, we always ask about birth and the gestational period. Was he a full-term birth? Was he premature? Was he late? Did you have any problems during your pregnancy with him? Were there any problems during delivery with him? And is he up to date on vaccinations, right? We will still use AVPU, but we'll use it a little differently in like, is he alert? So does he look at you when you walk in the room? Does he look at you when you talk to him? As far as verbal, does he look at you, or are his eyes closed until you talk to him? Do I have to pinch him, right? Or is he unresponsive? The Glasgow is a little different just because of their ability to answer questions and whatnot. So eye-opening for everybody, adults through infants, should be spontaneous. They should open their eyes and look around. Verbally, to commands, to loud voice, to pain, to no response. Motor response. A 9-month-old is not going to follow commands, right? Can you squeeze my fingers? But if you put your fingers inside their palms, they should grip that's a reflex. When you touch their palm, they should grab your fingers, okay? So to me, that's obey. Do they localize pain? Like if you do something like you do a finger stick, do they pull away from it? That's localizing, all right? So these other things, they kind of go the same. Verbal response. So with you and I, we're looking for them to be oriented and conversational with us. From 2 to 5, we just want to know that we're hearing things that make sense. And when they're less than 2 years old, are they, interacting appropriately, right? They're smiling at people. They're making sounds that are normal for them. They're crying appropriately, versus, now disoriented. With a 2 to 5-year-old, it might be inappropriate words. It might be just frickin' crying, or just, screaming for no reason versus grunting, okay? So we tweak this a little bit based on the age. And again, cut this out, put it up on the wall in your ambulance. Normal pediatric vital signs. So here, kind of funny thing with this, and that is, depending on what you read, respiratory rates tend to be a little different. So I tend to keep this simple to infant, pediatric, adult. Adult, 12 to 20. Most of what you read, except this chart, says children, pediatrics, 15 to 30. You see that on here, but you're seeing, 18 to 30, 15 to 30. And for infants, most of what I've read, including the EMT book, says 25 to 50. This says 25 to 60. My experience with this is when you get up over 60, they're sick. Most newborns are going to be in that 40 to 50 range. After kind of the first 10 minutes or so, they're not screaming anymore. But you see anybody at 70 or 72 a minute, that kid's sick. Sick. Either fever sick or respiratory sick. All right. So 25 to 50, and so it doubles. 15 to 30, 25 to 50. It's an easy way to remember that. Pulses, newborns, that's a big range, 100 to 180. Infants, 100 to 160. Again, most of these kiddos, you're going to see them in that 125 to 150 range for a heart rate. Toddlers, where now once they get to be about 3 or 4 years old, they're closer to normal pulses. At rest, 60, 70, 80 is normal, even for us. But when they're just up and moving around, to see them at 120 or 130 is not unusual. Whereas for me, 120 or 130, I've been up running around, I've been running around the house. So you're starting to see more normal pulses once you get to that kind of 3 to 5 year old range. Systolic blood pressures. There's not a lot of difference right here. But once you get to the school age, you're kind of starting to see more normal. 80 for a school age kid. So let's see, school age, let's say a 6-year-old, right? 70 plus 2 times their age. should give you 82 as a minimum. I'm not a huge fan of this number for that 6-year-old. 80, as a minimum 82. Okay. Most of them are going to be up in that 90 plus range, which, adolescent, 12-year-old, if we did that 70 times 2 plus, so let's say 70 plus 24 would give you 94. I'm not a fan of this chart for this blood pressure. I think it's low, as a minimum even. So that's why I love that 70 plus, right? 70 plus 2 times their age. If you've got a 1-year-old, 70 plus 2 is 72 systolic. That's perfect. Okay. Temperatures tend to be normal, although as an
Evan,
infant, yeah.
Sorry. The 70 plus 2, what age is that good till?
Well, I mean, if you look at this 12-year-old,
Mhm.
70 plus 24 gives you 94. That's pretty good.
Okay.
So, roughly that early teenage, 12, 13-year-old. And then after that, it should be pretty normal blood pressures. But you do see a lot of these 13, 14, 15-year-old skinny kids, that are 100 systolic. Not a surprise. But younger than that, especially, I love using that little equation for that. As far as temps, the infants 99 to 100 very commonly. Their little metabolisms are just through the roof, and if they're bundled up, they're going to be a little warmer. But after that, you're getting to normal temperatures for those kids. Everybody's a little different, right? When I was in my 20s working in the ER, I took my temperature all the time. I worked 5 8-hour days a week in the ER, and you'd be standing at the nurse's station bored. And I ran in the 96s for temperature like all of my 20s, because I took my blood pressure and my temperature all the time because I was bored. So I knew that 96.5 or so was normal for me. If I got up to 98, that was fever for me. So everybody's a little different. Some people will run a little bit higher than normal. Some run a little bit lower. Remember that thyroid will play a part in that with adults. You can get blood pressures on any patient. Typically, we don't do a lot of them under 3 just because it hurts. I mean, you've got 70-year-old women bitching because the blood pressure cuff hurts and they're pulling at it, right? And so, a 2 or 3-year-old, it's kind of hard sometimes to get a good blood pressure on them. Cap refill, number 1, right? If they get cap refill that's less than 2 seconds, their perfusion's good. Critically sick kids, unresponsive kids, I'm going to get blood pressures on those. And our physical exam, just like with adults, base it on your chief complaint. Do they need to head to toe, like with a trauma? Do they need head to toe because they're unresponsive? Or do they need focus because, well, it looks like bronchitis or bronchiolitis, so I'll do chest and belly. Or it's an ankle, so I'll do hip to foot. Mental status, right? Again, flat affect. Are they just like staring off into space? Are they unusually lethargic? So parents will go, oh, I can't keep him awake. He won't stay awake. Okay, mom, what's his normal nap time? 2 o'clock. Okay, it's 4. Has he had a nap? Well, no. That's not unusually lethargic. That makes sense. But if his nap's at 2 and he fell and banged his head at noontime and now at 1 o'clock you can't keep him awake, that's a different story. Okay. Parents come in and say, oh, he won't stay awake. It's fucking 1 in the morning. I can barely stay awake. Okay. Patterns of bruising, like we've talked about. Rashes and petechiae. Petechiae are pinpoint red spots. And they are not like, you see them like all over the place. So they're not abuse. They can be because of illness. Different illnesses will do it. Trouble breathing can do it. Clotting issues can do it. Now, rashes versus hives. Hives are bumpy and have texture to them. Most rashes do not. Okay. So he just broke out in this rash, and you feel it, and it's bumpy. It very well could be an allergic reaction, as opposed to just like, well, he's got a rash that goes with his diaper rash. Okay. Or hand, foot, and mouth, whatever. When he's crying, he should have tears. No tears, hypovolemic. Drainage or bleeding from the ear. Now, here's one of the things. Little kids will pop their eardrums. They'll get a bad ear infection. It comes on really quick. They've been screaming, yelling, pulling on their ear, and all of a sudden they get this little gush of bloody fluid. They probably just popped the eardrum. They'll be okay. But it's certainly something to go, oh, crap, okay. It's not necessarily like CSF or, I mean, if the kid didn't bang his head or anything and it's one ear and he's been pulling on that ear, it's probably from the ear infection. Signs of ingestion. Remember that little kids will put everything they can in their mouth to taste it. So do they have burns around their lips? We talked about fontanelles, right? They're wonderful tools for assessing hydration and intracranial pressure. If they're bulging and they're calm and quiet, I'm nervous. If they're bulging while they scream, oh, that's normal. If they're sunken in, they're dehydrated or bleeding. Little Buddha bellies. Little kids, little chubby kids have chubby little bellies. But remember that when I've talked about distended bellies in the past, I've compared fat jiggly bellies to a tight drum head. If the skin is tight and that belly's big and you push on it and it feels like you were pushing on the top of a drum, that's a distended belly. If they won't use an arm, they're protecting that arm, they're holding the arm, they won't let you move it, they won't let you touch it, or it's just hanging there and they won't move it, you gotta think about an injury to that arm. One of the things that's very common in kids is called nursemaid's elbow, and it's a subluxation of the radial head. All right, so a subluxation is like a microscopic dislocation, if you think about it that way. A dislocation is that like shoulders completely out of joint. With this nursemaid's, this subluxation, a lot of times what happens is like mom or dad are holding the kid's hands and swinging them around, which a lot of kids love that, and you do it and it's not anything harmful or mean, but in that pulling motion, it gets twisted just a little bit, and that radius gets just a little bit out of whack with the ulna, and it's very painful. They will not use that, and so they won't use it at all. They won't bend the elbow, they won't bend the wrist, and the ER doc will take it and they'll look at it and they'll go, oh, let me look, and they'll just give it a little twist and it pops right back in place, and the kid's like, yeah, it doesn't hurt anymore. Okay, so that's a very common injury in little kids called nursemaid's elbow. It can be done during abuse too, though. So the kid won't move his arm. Mom, what happened? And mom gives you one story and dad gives you a different one. Somebody was whipping the kid around by his arm, not in a fun way. So keep your eye on the kid. Things change your priorities, okay? Remember that kids respond differently to injuries and illnesses, okay? And they compensate really well and then fall off the cliff. So be suspicious with these kids or with any kid. They, except for these wicked fat little kids, don't have a lot of built up energy stores, right? They don't have a lot of glycogen built up that they can pull from, so their sugars can drop. based on their nature of illness or mechanism of injury, you gotta be suspicious shock and respiratory failure. And if possible, you take them to a pediatric center. In the Seacoast, that's not possible, right? We have Frisbee's ER and Wentworth Douglas ER and Portsmouth ER and ER's ER. But at the Elliott, if you're in Manchester, the Elliott has a children's ER. You know, they have an ER dedicated strictly to the kids, and they have people who specialize in pediatric medicine. So you got a sick kid, you're better off going there than CMC. So something to think about. Always use pediatric appropriate supplies. Yeah, if we got them, if you can find them. But certainly use them if you can. Now, pediatric size, this says LMA. I don't know of many BLS systems. I don't know of many medic systems that are using LMAs, but it doesn't matter whether it's LMA, laryngeal mask airway, or whether it's that King airway that we've been playing with. Use the appropriate size and use the appropriate volumes and rates for ventilating, right? Chest rise and fall, 10 to 20, 20, 20 to 30. Now, this little table lists volumes. So neonate, 6 to 8 milliliters per kilo. I can do that with a ventilator. I can't do that with a bag valve mask, okay? So you got to use a neonate bag and just chest rise. Once you get chest rise, done. Okay, we're not looking for a lot of chest rise. We're just looking for the chest to move up a little bit, and we're done. Adults, I mean, we use 6 to 8 for adults on vents. But again, I can't judge that I can't judge that without a vent. I can set a ventilator for, I can go, well, let's see if 6 times 100, that's 600. I can set the vent to do that, and it will do 600 exactly, give or take 1 or 2, right? However many, but you can't do that with a BVM. You just can't do it. So neonates, neonate bag, 30 a minute, okay? Infants, 20 a minute, 1 every 3 seconds, right? So a neonate, 1 every 2 seconds, 1 and 2 and 3 and breathe, that's 2 seconds. 1 and 2 and 3 and breathe, that's 2 seconds. With an infant, 1 1,000, 2 1,000, 3 1,000, 1 1,000, 2 1,000, 3 1,000. For a kid above, above that, 20 times, all right? Now, as far as immobilization, if the kid will allow you to do a cervical collar, use the appropriate size pediatric one. A lot of times you will do better off with a towel. And what I mean by that, I'll show you. Oh, I'm supposed to take this towel back to Florida and I forgot. All right, so I've talked about the term horse collar before. Back in my day of high school football, we used to wear these pads that were big white pads that came around our neck, a lot of us, and it was called a horse collar. And it would prevent our head from being hyperflexed or extended. And basically you can do that with a towel. You roll the towel up, you put it around the neck. I like to twist it a little bit, not so much that you don't want to be doing that with them. This is a stabilization, not strangulation. Put a couple of go around it with a little bit of tape, and that provides good motion restriction. I mean, I got to remember this for the airplane, for the flight down, because I could sit here and it'll hold my neck perfectly. And then you put them back in their car seat, or you leave them in the car seat to start with. Now, all right, the experts say don't use their car seat if it's been in a crash because the stability, structural stability could be, if it looks damaged, don't use it. The reason I like their car seats is because they're comfortable in them. They know the feel of them. They know the smell of them. They know where their Cheerios are hidden. they're going to be a lot more compliant in their car seat. And we know it fits them better than this stupid one that I've got that's not even really a car seat. So if they need fluid, you can start a line. State of New Hampshire, AEMTs can start an IV. That was one of the differences between intermediates and AEMTs. Intermediates were not allowed to start IVs on kids because, you know, it's magic. They're different.
Kevin,
here
when
we go.
if you start an IV on a kid, do you use one of those small, it's almost like a splinting board just to keep it in place, or?
So it depends on where I start the line. If you put one in like an AC or in a wrist, you generally need to splint it because they're just going to move their armor. But the splinting, it's going to set them off too. But if you're trying to run fluid through it, yeah, they're like most adults. You can remind them, and they'll straighten their arm out again. But little kids won't. They'll keep bending their arm. So yeah, most kids that have them in their AC or wrist end up getting an arm board put on them. So that's why I try not to start them there. So I don't. It's one less thing to fight with them over. You know.
Yep.
Good question. I'm glad you brought that up, 'cause I certainly forgot to mention it. Again, they can deteriorate quickly. Every 5 minutes, right? Especially if you've got a kid that you feel ballsy enough to throw an IV in, he's probably sick enough to reassess every 5 minutes. You know, yeah. You know, nebulizers, you can do nebs with blow-by on these kiddos, and especially because that fog's coming out at them, and you know they tend to kind of like that. Anything you do, reassess what you've done for treatment. Know the difference between adults and kids, and what you might have to do to treat them a little differently. But the basics of it's the same. All right, specifically a few different things. Asthma is asthma, okay? However, in these little kids, a lot of times, mom doesn't know they have asthma yet. So like probably the most common way that they get diagnosed with asthma is mom brings them to the doctor's office or the ER, like it's 2 in the morning, and they bring him to the ER, and they're like, he can't sleep, he won't sleep, all he's doing is coughing, and now I can't get any sleep, and so, all right, let's go into the history of the present illness, events leading up to it. How's he been the last couple of weeks, you know? Well, every night, sorry, something's distracting me. Every night, every night when I lay him down, he coughs and coughs and coughs. He's got asthma, right? Because what's happening is his bronchioles are constricted just enough that when he's up and moving around, it doesn't seem to bother him. You know, he might cough once or twice during the day. But anybody with asthma who's bronchoconstricted a little bit, you lay them flat, they get a little short of breath. And kids will cough to try to dilate their bronchioles. That's the #1 way we diagnose kids with asthma. So, but you could certainly go there and find them wheezing. Treat them the same way. Nebulizer, they may not take that mask, or they're certainly not going to hold that mouthpiece in their mouth. By the way, with nebs, I don't like the mouthpiece. I use masks for everyone. Because if you have a mouthpiece and you're holding on to that neb and you ask them a question, they'll take it out of their mouth to answer you. Leave it in your mouth. Okay, they'll leave it in the mouth, and then they'll take it out to talk to you again. Leave it in your mouth. Okay, and then they'll take it out to talk to you again. So I put a mask on them, and they'll just talk through the mask. With a kiddo, if he does nebs at home, Mom, does he use a mask or a mouthpiece? And I'll use the same thing, okay? Because he's used to that. In fact, I might use his. If he's never had a neb before, though, that mouthpiece, because you can do blow-by, is probably going to work better because it'll aim right at him. Now, you've got that little corrugated tubing that comes off the back side. I wrap some tape around that and close it off, so it's all coming out at him. So Now, cystic fibrosis is an overproduction, chronic overproduction of mucus, and it can be in the GI tract and or the respiratory tract. So, we talked about this with adults, but it's an onset while you're a kid, and you have this repeated chronic respiratory infections which cause scar tissue. So with this, when they're having a lot of trouble, a nebulizer will help them. They may or may not be wheezing, but with a nebulizer, you're putting more moisture into the bronchioles, and what that does is helps loosen up the mucus so they can cough it up easier. Kids get anaphylaxis, right? So pediatric dose of epinephrine, 0.15 milligrams, whether it be auto injector or drawn up and injected. So roughly 8 years old and above, you give them an adult dose. I hope you see a pattern here. Obviously, it's important. They deteriorate rapidly. Quickly identify things and do something to intervene. What do I see here and smell, right? Grunting. When they exhale, are they grunting, trying to push out, right? You grunt when you do a bench press because you're trying to push that rep out. They grunt to try to push that air out, okay? The more you grunt doing bench pressing, the harder you're working. Works the same way when you're grunting to exhale. Nasal flaring, retractions between the ribs. So remember, their intercostals are very weak. Their diaphragm's doing most of the work. That's why they're belly breathers, because the diaphragm's pushing the abdominal contents out of the way. So if their diaphragm is doing so much work and they're working so hard that they're creating a ton of negative pressure that it actually sucks the intercostals in a little bit, causing retractions, that's a bad sign. And as they get hypoxic, they become bradycardic. So again, as they're going through distress towards failure, their heart rate will climb just like ours will. But as they go into respiratory failure, they get bradycardic. Now, some of the things to look for: the stridor, crowing, wheezing, grunting, hoarse, snoring, cough, gagging, gasping. If you hear liquid in the airway, suction it if you can. Have them cough it up if you can. Tachypnea and bradypnea, so rapid respirations, slow respirations. Tachy and bradycardic, listen to lung sounds, right? Do I hear good air movement? SATs less than 95. Remember, these kids are generally healthy and should have normal SATs as opposed to your COPD, old COPD, right? Are they tripoding? Do they have retractions? Neck muscles. So if you're struggling to the point that you're using neck muscles to pull up on your rib cage, I don't know how visible that is, but if you see neck muscles pulling, that's bad. Head bobbing, they're tiring out. When they can't hold their head up when they're taking breaths, they're getting tired. And when they're getting tired, they are failing. Not they're heading towards failure, they're failing. Cyanotic or pale, fatigue, lethargic, seesaw breathing, unresponsive limp, start bagging them. Don't even go to a non-rebreather, just start bagging them. Immediately intervene in that lethargic limp or cyanotic kid because he's dying. Not like he's failing, he's dying, okay? Pediatric patient, dry cough, especially at night. Humidified oxygen if possible. Most of us don't have it. So do I need a little oxygen, a lot of oxygen, or do I need to bag them? For that patient in respiratory failure, ABCs, ventilate, high flow O2. IV fluids are great in these respiratory patients because remember when you're working hard to breathe, besides the fact that your respiratory rate might be twice as much and you're exhaling a ton of water vapor, fluid, you're also working hard. Your skeletal system, your muscular skeletal system is working hard to breathe harder, breathe faster. So you're using up more with an increased metabolism as well, okay? So a line and fluid for these kids is often very handy. And you see a lot of medics don't do it. You'll watch these medics and AEMTs start IVs on well, he's got asthma. I'm gonna do an IV and then a neb. No, dumbass, do the neb, then start your IV, but then they don't give them any fluid through it. Well, I don't want to put them in failure. We're not giving them 3 or 4 liters of fluid. We've got this 45-year-old asthmatic or 9-year-old asthmatic. We're going to give them a fluid bolus. Give them 250, right? Kids, 20 mLs per kilo is a great starting point for a fluid bolus. He's 9 years old and weighs 75 pounds, 30 kilos, 20 times 30, 600, right? So a 250 bolus on that kid's fine. 250, 250, 250, okay? An adult with asthma, give him a liter. You're not gonna hurt him. Be prepared to start bagging them. Okay? HIV, so influenza B, all but eradicated, the vaccine all but eradicated epiglottis in this age group. All but. That's like saying, hopefully, when I defibrillate somebody, right? So we do still see epiglottitis. It's not super common. It is more common in younger people. We do occasionally see it in adults, though. I already said, don't agitate them. Don't put anything in their mouth. Croup, so laryngotracheobronchitis, lower airway, viral, worsens at night, seal bark. Humidified oxygen's fine, but for the most part, cool air, and they're gonna be fine. So like if I went to a house and we're gonna transport the kid, like you walk in and you know the kid's got a little croup, but you know mom and dad just aren't going to, they want the kid in the ER, they're not gonna handle this well at home, right? So like, okay, yeah, we're gonna transport the kid, even though he looks pretty good. Tell you what, mom and dad, while you're getting his diaper bag and you know, whatever, why don't I step outside on the porch and wait for you? Let him have a little bit of cool air while we wait. By the time we get to the truck, he's probably gonna sound better. We get in the back of the truck, I'm gonna leave the heat off. I mean, unless it's like 30 in the back of the truck. I'm not gonna crank the heat up. I'm gonna bundle him up in a blanket or a couple of blankets. We'll leave the heat down, keep the air nice and cool in the back of the truck. If he needs oxygen, right, his sats aren't hot or his lung sounds are crappy, well, yeah, I'm gonna do oxygen and nebs and that. But most of these croupy kids don't need anything other than cool air. If you hear some wheezing though, yeah, absolutely, give them a neb. If they have a history of asthma, it may very well trigger it. Pertussis is that whooping cough. It's sometimes fatal. It's very often fatal in little kids. And look how long it can last, all right? So this is something where we're gonna treat them symptomatically. If we think they need oxygen, we're gonna give them oxygen. If they need a neb, we're gonna give them a neb. They're probably gonna end up in the hospital for quite a while. They're probably gonna end up with some steroids, things like that. Okay, I believe it's viral. I may be wrong though, but I think it's viral. And this they're saying it's DTaP. Everybody else, it's Tdap, tetanus, diphtheria, and pertussis. But they're recommending it now since I think it was like 2007. If you get a tetanus shot in the ER or at your doctor's office and you haven't had pertussis since you were a kid, they'll give you a Tdap. Bronchiolitis, acute viral lower airway disease. Kids typically 2 months to 2 years of age. Looks like, acts like, smells like, and it gets treated like bronchitis. Most bronchitises are viral also, by the way. You go to the ER though, they always give you, or your docs, they always give you antibiotics for it. Up until about a year ago, we started going, no, it's bronchitis, it's probably viral. And if you give a ton of antibiotics for everything, that's part of how you end up creating these super bugs like the MRSAs. So they get wheezing, they get tachypnic, and they look like they're in distress. So we treat it just like we would bronchitis, right? Nebulizers. RSV is this really kind of ugly respiratory thing that kind of looks like bronchitis. A lot of times they're not wheezy though. They're very junky, lots of mucus. Their nose is all just green shit draining out of it. It's viral and it's very contagious. And they get pretty sick and pretty dehydrated. Treat them symptomatically. You know, if they need oxygen, oxygen. If they need a neb, give them a neb. If you think they need a line, you throw a line in them. This is one that's a swab, a nasal swab. So like, and a little kid comes into the ER nowadays, they get a couple of swabs at the same time. They'll get an RSV, a flu swab, and a COVID swab all at the same time in the nose. Cough and fever, typically the early signs for pneumonia. And then they start to get a little cranky, irritable, vomiting, some respiratory distress. Any evidence of respiratory failure? Absolutely, go ahead and bag them. CPAP is not so hot on a kid because they've got to be compliant with it, right? So being unresponsive and not able to maintain your own airway is a contraindication to CPAP. Most adults, you have trouble with CPAP, keeping them compliant with it. Kids are not, they just are not going to let you strap something to their face like that. Upper respiratory infections, so rhinorrhea, runny nose, and cough is common. Anaphylaxis presents just like it does with adults. Ask them about allergies, especially prior allergic reactions. Do they have an EpiPen? Have they used their EpiPen? If you think they need it, I'm going to give them my EpiPen. Let the parents keep theirs for later. CF, as we've talked about, thick secretions do obstruct the airways. Again, nebs work wonders for these people, and not necessarily to bronchodilate, but just to help loosen the mucus up so that they can cough it up easier. No reason to withhold oxygen from kids. Now, newborns, we talked about the fact that too much oxygen, oxygen narcosis, they can go blind, but you know, they're blue and you've bagged them for 30 seconds and they're not pinking up, oxygen. That 3-year-old, you don't have to worry about it. You know, if he's in respiratory distress, oxygen. CPAP, like I said, I just don't see how I don't see how I could do it without sedating the kid. And that's probably not a good idea in somebody with respiratory failure. I do it with adults, but cardiovascular disorders, again, usually because of hypoxia. However, adolescents, these teenage, you know, 15, 18, 19-year-olds even, you hear about these high school and college kids, they're in really good shape, and they're on the basketball court, and they drop. And we really don't know why. So a lot of schools now do have defibrillators, both for students and staff. The commotio cordis, right? The kid's playing basketball and somebody headbutts him in the chest at just the wrong point. That kid will be in VFib, okay? But most of the time when kids go into cardiac arrest, they are not in VFib. They are in PEA. So they have a normal looking EKG, normal looking tracing, but they don't have a pulse to go with it. So pulseless electrical activity. Little kids, whew, they can stay in PEA for, I've seen it almost 2 hours. So like I used to work with a couple of docs who would not declare the kid dead until he was in asystole. And so they'd like leave the monitor on but stop compressions. We're not working in him anymore, but I'm not going to declare him dead till he's in asystole. And he might go hour and a half and still have some QRSs and stuff. It's brutal. If you're not, and we'd be arguing with him, look, the kid's dead, just fucking say he's dead. Let's turn this monitor off and let's stop torturing ourselves with this. So unfortunately, because of that, I've gotten to see the fact that they will stay in PEA for a long time when their brain is toast, their heart's not beating. It's kind of ugly. So PEA is probably the most common pediatric rhythm. If they have a true cardiac event, it's probably congenital. It could be valves, it could be a hole in the heart. So those all lead to bad perfusion, hypoxia, treat for shock, be aggressive with them, oxygenation wise, etc. SIDS, we've talked enough about that one. This ALTE though, there's also another term for it now. I think it's BRUI. I can't remember what it stands for, but it's the same thing. Apparent life-threatening event. So we would get called to the house, or the parents would show up at the ER and say he was choking, or he couldn't catch his breath, or I thought he was, whatever, he passed out, I thought he seized, I think, but now he looks perfect. And you're like, yeah. Okay, and here's kind of the typical shit that goes on. Okay, mom, is this your first baby? Well, these things happen, and they get treated like idiots by EMS and the ER, and 24 hours later, the kid's friggin' dead. So these, whether you call it ALTE or I think in the New Hampshire protocol now it's BRUI, but they had some sort of a thing where they stopped breathing, or they turned blue, or they went limp, like passed out, or choked or gagged. And when we first had this protocol in New Hampshire, the study I read with it was that 60% of these kids would go on to have a near fatal event within 24 hours. So take this shit seriously. You go to a 911 call and mom says the kid turned blue and stopped breathing, go, okay, how about we get he looks great now, mom. That's wonderful. How about you get his car seat and get his diaper bag and we go for a ride into the ER? Okay, don't be the reason. Don't talk them out of it. Don't sign them off. Don't downplay it. Something happened, okay? SIDS, if you're gonna work the kid, work the kid. If you're not, it used to be, don't disturb the body or move anything. Pretty much now, though, it is accepted to allow the parents to hold the baby now. I know this says don't move anything, don't, but the medical examiner's office in New Hampshire has taught classes for me, and the chief assistant said it's okay to let mom and dad hold the baby. They can put these pieces together, okay? Where, on the run sheet though, how was the child lying in the crib or with mom and dad or however, right? So describe the positioning, how you found him or her, what you saw, those things. But then, it's a very emotional theme. Keep your shit together would be a good way for me to describe this. The first SIDS I ever did, I was in medic school. I was an intermediate working with a medic who was an experienced medic until probably that morning. I had quite a bit of respect for him. It was a 5:30 on a Sunday morning. So the fact that I can tell you that when that summer morning was the late spring of 1988 tells you something, right? 5:30 on a Sunday morning. He's driving. He pulls up to the front of this apartment building, and it's a old house that's been made into, you know, like 4 apartments. I climb out the passenger's door. I'm starting to pull equipment. He doesn't come around the front. He bailed out of the truck and went into the house, into the apartment. I have no idea what apartment we're going into. There's like 6 different doors. I'm looking for him. I'm yelling to him. I'm pounding on doors. I've got the first in bag, the O2 bag, the monitor, the suction, the PD bag, all this shit, right? I'm a Sherpa, and I don't know where he is. It took probably 10 or 12 minutes before I got into the right apartment. And then when we came back out, he was in back, right? He's the medic. He's in back with the kid. I climb into the driver's seat. The truck's in gear. The e-brake's not on. The truck's in gear, and it's just sitting there waiting for us because he literally bailed out of the goddamn ambulance and left it in gear. All right. Did no good for this kid at all. Right. I mean, the kid was dead, but it just, that has stuck in my mind. Right. I tell people, try to learn something from everyone. Sometimes it's what not to do. That was a good example of it. Right. So anyways, be empathetic towards the parents. Even if you think it's their fault, don't say it, right? Don't say it. But be empathetic for them. And like I said, if you want to hold them, and that's right from the New Hampshire ME's office. Oops. So how was the kid found? Where was the kid when the parents found him? What kind of surface? Pillows, loose bedding, stuffed animals, and other objects. The kid's not supposed to be sleeping with those. So usually it's an asphyxiation issue. What clothing did the child have on? Was he in a crib? Were there any signs of defects in the crib? Now, some of these things that with SIDS deaths over the last 25 years, the medical examiners around the country have pushed a lot of these changes. There have been cribs that have been taken off the market because of this medical examiners group. I don't remember what their professional organization is. This new education about, the kids sleeping with just a sheet, with no pillows, no bunting, no stuffed animals, all came from these MEs who were, doing autopsies on these kids. All right. So, defects in the cribs. Could the kid have been wedged? What's a general condition? Who was present? Was there, rigor mortis or liver mortis? So rigor mortis is the body is stiff. Liver mortis is that discoloration that you get, dependent discoloration. So if the kid is face down on, or anybody is face down on a bed, for example, the dependent part, so the part that's down against the mattress, is going to be this blue, purple, red discolored, because blood is settling there, right? When blood's not being pumped, blood will leak out of vessels, leak out of tissues, and gravity works, right? It will settle down into those what we call dependent areas. From about halfway up his side all the way around his back, he's going to be freaking pale white, like he's already, in a casket. But everything else will be this dependent color, this mottled color. So that's liver mortis. Rigor mortis is stiff. If I remember correctly, it's like 12 hours or so for rigor to set in. And then it goes away, like 6 to 12, depending on the person, the heat, all that stuff, okay? I've seen it earlier than 12. I've seen it later than 12. And it will go away at some point too, by the way. You know, I don't remember exactly. It might be 24 to 36 hours, but what was skin temperature? Were there any marks or apparent injuries? So these are all things to just kind of make note of in your mind and to document on your run sheet, and to tell the PD if you have suspicions. So that dependent modeling can look like bruising. Don't misinterpret that. If you're going to work the kid and the parents are not like getting in your way, trying to stop you from working them, you know, then certainly have them there with you. They certainly require emotional support. As I said last night, there's a group in New Hampshire called Victims Inc., and they are an advocacy group that started out for family members of people who had been killed because of DWI, and it's now kind of just morphed out into emotional support for everyone and anything. They're very well known throughout Rockingham and Stratford County, but they'll pretty much go anywhere in the state. We had a death up in Ossipee, Tamworth, I don't remember, someplace this summer. And Carroll County, you know, we asked, and Carroll was like, why don't you call them, because they'll have questions for you. So I did, but they had no issue with it. They said, yeah, no problem, we'll be up there. Google says it's going to take me an hour. Give me an hour and 10 and I'll be there. So wonderful. They'll meet you at the hospital. So like you could call Carol or Rock and say, you know, Epping A1, can you start Victims Inc. to Exeter's ER, please? We're going to be transporting a cardiac arrest. And they will. They're wonderful, wonderful folks, all volunteers. And they help with that emotional stuff. They know what support groups are out there. Hopefully, like if you go to the hospital, the social workers at the hospitals can get involved with it too. Now, be prepared for how you feel and how your partners feel. All right, talk about it. Watch out for each other. Some infectious diseases, meningitis. So meningitis, the meninges are the linings around the central nervous system, right? Spinal cord and brain. It can be meningitis, so itis being, right? Oh God, that's like chapter 5, right? Inflammation. So inflammation of the meninges. Hang on. Viral or bacterial? Bacterial is the worst one to have. The nice thing is you can take antibiotics for it, but you'll get sick as hell with viral. They can give you antivirals. A lot of the antiviral meds will make you feel crappy too, though. It's one of the reportable diseases. So if you take somebody in that's got meningitis, they'll call your EMS system, and you should then go and be seen, and you'll end up on, if it's bacterial, you'll end up on rifampin is one of them. Rifampin's kind of cool because it turns all your secretions yellow. Like if you cried, your tears would be yellow. Sweat can be yellow, or orange, I'm sorry, orange. Lots of body fluids go orange, which could be interesting on a first date. So meningitis. Yeah, I'm full of these trivial things. So meningitis, if you headache, crushing headache, high fever, step back and have them touch their chin to their chest. This maneuver stretches the meninges. And if they have meningitis, they won't do it. It hurts too much. And they look sick. They're wrung out, they're exhausted, fever, high fevers like 103, 104s, you know, just really do not feel good. Lights hurt their eyes, okay? They can seize, and they can have altered mental status too. Most of them just look like they feel like shit, but they will not do this, will not do it. So at that point, if you didn't already have an N95 mask on, put an N95 on, eye protection, put a gown on. This is as contagious, if not more, than COVID is, right? So they're going to end up getting a spinal tap. So the ER doc or whoever is going to go in with a special needle right into the spine between the vertebral bodies in the back, and they're going to draw some CSF off, and they're going to look at it to see if it's clear or if it's cloudy, bloody, icky looking, and then it's going to go to the lab, and they're going to look for white blood cells in it, and then they'll test it from there for viral or bacterial. So meningococcal bacteria can enter the bloodstream and then into the organs and skin, fever, chills, vomiting, diarrhea, all kinds of pains. You basically hurt everywhere. And meningococcaemia can also be fatal. But it's bacterial, so antibiotics. Now with kids, seizures, everybody assumes that the kid having a seizure is febrile, right? A fever seizure, and it can be. A kid who spikes a fever quickly, it's kind of like triggering a circuit breaker in your house. If you apply too much energy need, you turn on too many things at the same time, you'll pop a circuit. It's kind of the same thing. And boom, it just, the fever climbs too high, too fast, and it triggers a seizure. It is very common. It is common genetically. So like if they have a sibling that's had a febrile seizure, there's a good chance that they have a febrile seizure. 25 years ago, I read a study though written by a pediatric neurologist who said that we assume it's febrile too often, and that his study showed, you can read different studies, but that 90% of all seizures in kids were actually neurological, not febrile in nature. And I didn't agree with that from what I saw in the field in the ER. So I started asking a bunch of docs, the docs I worked with, the ER docs, the pediatricians, and they all said, that's bullshit. And so I was, okay, so, like I said, you can find any number of contradicting views with studies. But what it did for me was it made me realize that I need to be more aware of the fact that it may not be a febrile seizure. It very well could be toxins. It very well could be a seizure disorder. It could be drugs. It could be hypoxia, glucose, right? Hypoglycemia. So when I look at my differential diagnoses for seizures, I put all those things on it, and fever's the last one on the bottom of the list because that's not going to kill the kid, right? We get to, we get through our sample and our OPQRST and, events leading up to it under the E, right? So mom, how's he been feeling the last couple of days? Well, he's been kind of lethargic and sleeping a lot. And this morning he spiked a fever. Oh, how long ago did he spike the fever? Well, he got really hot about an hour ago. I took his temperature and it was like 103, and you take his temperature now and it's 104. You're like, all right, everything else looks good. It's probably febrile seizure. But you know what, mom? Let's take him to the ER. He's awake now. Give him some Tylenol. Let's take him to the ER. Hypoglycemia, right? So this would be your type 1 diabetic who's had insulin, right? This is not how you're going to find them. You're not going to find a new diabetic because he's hypoglycemic. You're going to find the kid because he's hyperglycemic. Which, sure, he could seize with hyperglycemia, but it's not as common. So, this 3-year-old had a seizure. Mom, what kind of medical history does he have? Well, he was just diagnosed with diabetes. When did you give him his insulin? 2 hours ago. Okay. When did he eat last? Well, he ate right afterwards. Did he eat all of his food? Oh, I think he only ate half the sandwich. And you check his sugar and it's, 20. Okay. So keep hypoglycemia right at the forefront with these kids. Trauma, right? Mom, has he hurt himself? Has he fallen downstairs? Right? Look at his head, right? Look for signs of trauma because it could be that head bleed and it could be a tumor. So in the ER, when we see anybody with their first seizure, they always go right to CAT scan because we're hoping to see nothing. Unfortunately, kind of commonly, we'll see blood or tumors. There's about 50% of all seizures, though, that go undiagnosed. They're like, we don't know what caused it. They call them idiopathic. We don't know. I've read studies that say every person on the planet will have one seizure in their lifetime. And we don't know why. But tumors certainly can cause it. So again, febrile, it's a short seizure with a short postictal period. Kid wakes up pretty quickly, and it's related to the fact that the fever jumped like that. And here's the other thing. You'll see the parents have them all bundled up, all bundled. They get their diaper on, they got their onesie on, they've got a sweater on, they've got a jumper on, they've got, and then they're wrapped in 17 blankets. Whoa, 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 mom. Let's take a temperature. Oh, it's 105. How about, when was his last Tylenol? And how about we get him out of all this shit? We want him uncovered just to the point where he doesn't shiver. Because if you uncover him too much, he starts shivering. What's shivering do? It produces body heat. Okay? So we just want him uncovered, but if he starts to shiver, put another blanket on him. So AEIOU tips, right? What is that? What do those stand for? So I know there's alcohol in there, right? What else? How about
endocrine?
Yeah, so endocrine, your diabetics, or electrolytes, insulin, your diabetics. What's O?
Oxygen.
Opiates. Urine, uremia, so urinary tract infection. How about T? What was that?
Trauma?
Head trauma.
Trauma?
Yep, trauma. Or head trauma or hemorrhagic shock, right? I, infection or intracranial pressure. P for
Poison.
poisons and psychiatric. So this is a little odd because kids do this too. People will fake unresponsiveness for attention, to make people feel guilty. Okay. They'll fake seizures as well for the same reason. And then S is seizures and syncope. So there's lots of different things that can go with this. And it's a mnemonic that, I have trouble remembering at times because it kind of goes out of order with the way I was taught it. But just keep in mind that there are other things, like I said, other than fever, which will cause seizures. Hydrocephalus, water on the brain. Hydro, water, cephalus, brain. So too much cerebral spinal fluid. So what that does is it causes an increase in intracerebral pressure. And if they're little enough, you'll get that bulging fontanelle. Okay. So what these folks usually end up having is a ventricular shunt. So it's a little drain tube that fits. So the two halves of the brain are called ventricles, and they will put a drain into the center to drain off that extra CSF. And the drain goes down through and ends up in the esophagus somewhere and just drains into the GI system. So the problem with this is if that shunt gets occluded, like let's say some material gets in there and like clumps up, and it won't drain anymore, they become symptomatic again, like headaches start, and then they can have alternate mental status and seizures and things like that. So you may very well get called for 911 because the parents say, my son's got a shunt in his brain, and they said if he gets a headache, he has to go to the ER. And you're like, oh, he's just got a headache. Oh, wait. Oh, the ventricular shunt isn't allowing excess CSF to drain. Oh, this is just like having a head bleed. We got to go. And he's got to go to a neuro center, right? So for us, Portsmouth Hospital, right? They're the ones that deal with this stuff. In kids, so usually, so this term, usually insulin-dependent diabetic, that's not a good term. That's not a good phrase because a lot of type 2s are insulin-dependent. In kids, it's generally type 1 diabetes. Their body's not making insulin or anywhere near enough insulin. So they have to go on insulin, and it's for life. Type 2, right, they're resistant to insulin, so they need a little help. This slide says that's increasing in kids. My guess on that would be it's more like the big, the really fat, out of shape kids. Just like as an adult, if you're super overweight and you're out of shape, you tend to be a type 2 diabetic. But what we see more of that I'm aware of is type 1 diabetics being diagnosed in their teens to early 20s, adult onset of type 1 diabetes. So, with any of these kids, DKA is probably one of the ways that we find them, right? They get super sick and they've got DKA going on. They're, Kussmaul respirations and they're acidotic and, they end up in the ER and they, that's how we diagnose them. Or it's that whole drinking a ton of water, always hungry, never gaining any weight, peeing all the time. And they dip the urine and go, oh, there's a lot of sugar in the urine. They're diabetic, type 1. Now, if their diabetes is not well controlled, right, you can end up with cerebral edema. And obviously, if you're taking insulin, if you're not careful, or even if you do everything right and you're a little sick, you can dump your blood sugars. So hypoglycemia. So any patient, alter mental status, first thing, get a blood sugar. Okay. Now, another thing to look for with little kids, as far as, are they diabetic maybe, is really bad diaper rashes, just all the time, and yeast, that white cheesy, just like everywhere. Okay. So those are also signs of diabetes. Lethargic and malaise, the weight loss, the thirst, frequent urination, right? Because their body recognizes all this extra glucose in their bloodstream. So how do we dilute that? How do we bring that level down? We pull water out of our cells and out of the interstitial fluid into the bloodstream. We try to dilute the sugar from 800 to 600. Then the body says, well, I'm dehydrated and I need more fluid to dilute the glucose more. I'll drink a ton of fluid. I'll drink a gallon of fluid and I drop it from 600 to 500, whatever it is, right? But then the kidneys go, holy crap, that's a ton of extra fluid in my bloodstream. I better pee a bunch of it out. So it's a vicious cycle. Super dehydrated to go with it. So, you get blood sugar of 300, 400, 500 or high on a 4 or 5 year old, if you can get a line in him, give him some fluid. If you can't, and he's not puking his guts out, have him start drinking whatever he likes to drink, without sugar in it, but have him start drinking. So, right, dehydration, the ketone breath, that acetone breath, which I think I've mentioned before, there's like 40% of the world's population genetically can't smell that. It's just something in our genes. And I'm one of them. I don't smell this on people's breath. I also don't smell alcohol on people's breath. It's the same thing. But a lot of people will smell it. Could smell that because we're trying to help the buffer system with the conversion of lactic acid to carbonic acid and breaking that down into water and CO2. And that hyperventilation blows off CO2, which allows for that conversion to take place. Decreased level of consciousness, pretty common. Hypoglycemia, right? They took their insulin and didn't eat. Took it, didn't eat enough. Took it, ate perfectly well, but they're sick, so their metabolism's high. Down it goes. They took too much insulin by accident. Down it goes, right? So quick onset, altered mental status, behavior changes, pale, cool, extremely diaphoretic. They can seize. So somebody tell me, if you're going to assess a kid for dehydration, what are some of the things that we talked about and what might be something we haven't talked about?
Talk about the skin turgor and the tenting.
Yep, perfect.
The fontanelles being sunken.
Very nice.
Cap refill.
Yep, cap refill, good.
Dry cough.
Dry cough. No, dry something else though. How about,
Mouth.
yeah, mucous membranes, dry mucous membranes inside their mouth, inside their nose. Yep. And what else would go with that that's supposed to happen but doesn't?
Lack of tears when crying.
Beautiful. Yep. When you're crying and sobbing, you should have tears running down your cheeks. Those are great answers. Now, things that lead us to hypovolemia, gastroenteritis, right? Vomiting, diarrhea, belly pain, not uncommon. Constipation, super common in little kids, right? They're not eating right, or they're getting too much of one thing, not enough of another, whatever it might be. It's not uncommon for kids to be constipated. Vomiting and diarrhea, so gastroenteritis, inflammation, infection in the stomach and intestinal tract, which can be viral. Most times it's viral, but it could be from foodborne illness like salmonella, things like that. She's got the food poisoning. Belly pain, appendicitis, right? So we all think of belly pain or of appendicitis as right lower quadrant pain. My oldest boy and my middle boy have both had their appendix out. And one of them was very kind of classic, like it's right here. The other one had general belly pain for a day or two, not pain, but just kind of uncomfortable. And, but it lasted a couple of days. And we took him to the ER, and I'm like, I think it's his appendix. And the ER doc, who, I work with, no, it's not his appendix. And I go, I think, and as we're sitting there, Brian goes, this pain is now kind of like right around my belly button. In the last probably 10 minutes, it's just kind of gone from all over to like, and I went, yeah, it's appendix. And the doc goes, no, it's not. So we'll send him for an ultrasound. And the ultrasound didn't show anything. And he goes, we'll call the surgeon. And by that point, that pain around his belly button had traveled straight to his right quadrant. So it went from general to specific and then traveled down. And surgeon cut into him and gave us a picture, did laparoscopically, gave us a picture of the appendix, and it looked like a double appendix because on top of it was a pus pocket that ran the entire length of the appendix. And he said, yeah, another half hour that would have popped. So he never had nausea, vomiting. He was uncomfortable most of the time. So we think right lower quadrant pain, but that may be a late sign for it, okay? Excuse me. UTIs. Little girls are more frequent victims of UTIs than little boys, right? Just remember that diagram we showed with the female, anatomy. That that urinary meatus to the urethra up to the bladder is only like yay long, and it the meatus itself is back inside the vagina where it's warm and moist, you know, and so bacteria love that environment, as opposed to boys who, you know, shake it 3 times and, you know, it's dry, and it's a much longer urethra back to the bladder. So, and you know, little girls sit in sand and mud and dirt just like little boys do, but you know, it's a different structure, so not uncommon. The DKAs, hernias. Remember we said the abdominal wall is not all that mature yet, right? When you're young, when you're little. So our umbilical cord, our belly button, where the umbilical cord comes out, there's a little bit of an opening in that abdominal wall for those vessels to pass through. So if that stretches a little bit, you can have an umbilical hernia, where your belly button goes from being an innie to this, you know, baseball-sized outie, as well as the fact that down in your groin, inguinal, you can have that tear, or a little slightly bigger opening and have some bowel stuck in there. Bowel obstructions. Intussusception is kind of this folding on itself of the bowel, which a lot of inflammation and pain from that. Volvulus, I've completely drawn a blank. Somebody look that up for me. Pyloric stenosis. So we have 2 sphincters on our stomach, the cardiac sphincter and the pyloric sphincter. The cardiac sphincter is at the top, closest to the heart, and the pyloric is down at the bottom, leading out into the duodenum, which is the first section of small intestine. Stenosis is a spontaneous closing of an opening. So the pyloric stenosis is that sphincter is closing, and you end up with abdominal distension and pain because the food you're eating is not going anyplace.
Hey, Kevin,
Yeah.
volvulus occurs when the intestine twists around itself and the mesentery that supports it, creating an obstruction.
Thank you. Yeah. So it gets twisted around and it's kind of like tied in a knot. So besides the obstruction, you also get obstruction of blood flow in the mesentery. So you can have bowel infarct with that, as well as obstruction. Thank you very much. And swallowed foreign bodies. Kids put everything in their mouths. Cigarette butts. 1 cigarette butt will kill a kid. Batteries are bad. The GI guys go after batteries because of the acid that's in them. Pretty much everything else, unless it's like sharp, like an open safety pin, and yes, kids will swallow safety pins, or jacks, you know, like the little jacks, you bounce the ball, pick up the little sharp starred jack. Kids swallow all kinds of stuff. Unless
Kevin,
yes.
down at Children's, I believe it's Children's Hospital in Boston, they have a wall hanging that shows things that they have over the past 100 years have pulled out of kids.
Yeah.
That, you know, stuff that they've swallowed. It's incredible. Tacks,
Yep.
jacks, dice, batteries.
Yeah.
You know, it's just incredible at what they've pulled out.
Yeah. So the rule of thumb with that is, if it's not sharp and it's not a battery and it's not a cigarette, if they can swallow it, they can pass it, and they'll send them home to watch. But if it's something that will cause, you know, damage, like coins, kids swallow coins all the time. And as long as, and this is the great part for the parents, okay, mom, you got to go through that poop for the next 3 days. And if the coin doesn't come out or he starts to have pain, bring him back in. But pretty much, like I said, unless it's going to cause damage, if you can swallow it, you can pass it, because the risk of going after it is more, it's more risky to go after it than it is to let it go. Conjunctivitis, super common, right? The pink eye. Just inflammation, infection of the conjunctiva. So the eye gets super red, weepy. They wake up in the morning, their eyes are crusted shut, and it's super contagious. So like I've had people come into work with it, and I go, you got to go home. You can't be here. I'm fine. No, you have the pink eye. People, I love using that term. But you got the pink eye, and it's contagious, and I'm going to end up with it just being in the same room as you are. It's that contagious. Okay, it's treated easily though with eye drops or ointment. Styes, they get this little like kind of like P-shaped inflammation, area of inflammation, and it's just a little gland that's kind of plugged and swollen. Hot packs, for several days to a week or so takes care of that. Chalasia is this another weird lump, but it's an oil gland on the eyelid, and quite frankly, I'd look at it and go, it's a stye, right? So it's more common though in adults and kids. Cellulitis is around the eye. So cellulitis, inflammation, infection and inflammation of skin or underlying tissue, right? Well, if you get that around the eye, it's an emergency because it can affect the eye, and therefore, whole blindness thing, right? Foreign bodies in the eyes, ears, and nose, we see those commonly. We see lots of stuff stuck in ears and nose. Kids will stick things like peas in their nose. Why? Because it fit. And it's mush, and it doesn't want to come out, and they end up, sinus infections and all kinds of crap. Ear infections are the otitises, externa and media. So the dividing line on that is the eardrum. If it's behind the eardrum, then it's otitis media, and if it's the ear canal on the outside of that, it's otitis externa. And kids they'll pull on their ears, like, and they'll just pull and pull and pull. Stick their fingers in there. Okay. Nosebleeds are not uncommon. And then pharyngitises, sore throats, inflammation of the pharynx. Behavioral, just like any adult, right? Kids can have all these different, depressions and bipolar, anxiety, eating disorders, impulse control, addictions. And so a lot of addictions are in fact genetic. And so, mom and dad, or mom or dad's an alcoholic, good chance the kid's going to be, especially if he's in that environment and, there's no real help or education on why not to be. And then think about this, that just kids experiment, I was raised believing that drugs were bad. Okay. And I was pretty lucky. I never really did anything for drugs as a kid. Except I drank, because drinking was okay, right? My dad didn't drink. My mom would have drinks, but I can't remember ever seeing her drunk. My dad was a dick when he was drunk, so he stopped drinking when he was a teenager. But I drank. My friends drank. A lot of my friends did a lot of dope. I never did. But it's there. It's there for the asking when you're a kid. Anyways, it's out there. I'm sure none of you ever drank when you were a kid. Suicide risk increases with age into the adolescence. And most of these people don't want to hurt us, right? If they're having a behavioral event, a crisis, they don't want to hurt us. They might accidentally, they might intentionally, but we got to keep in mind our safety regardless, okay? Just because it's a kid doesn't mean, he can't stick something in your back or your side or shoot you or punch you or kick you in the junk, okay? As far as poisonings, kids are curious, right? How do they learn? They smell things, they look at them, they feel them, they taste them, okay? so they ingest them. I think that, and they don't know any better, so they don't understand cause and effect yet. They get dragged into the ER and get a NG tube stuffed down them. They learn cause and effect, but until that point, they don't know any better. Supervision and childproofing is a big thing. You know, my generation, my parents didn't childproof anything. They caught me mixing rose poison into the cookie dough one day. My mom had gone out to the mailbox, came back in. I was sitting in the sink mixing poison into the cookie dough. I was trying to help, right? Luckily, she figured it out. But my generation also got better about that because somehow we lived through that stupidity. But if I'm going to take my young kids or grandkids to my mom's house, my mom doesn't have shit childproofed, right? So you got to think about that in your own life with your parents and grandparents. But also you got to think about it for your patients, like what's available. This kid's limp and flaccid. Why? And look around the house. What's available to this kid that he might have gotten into? Okay. Drugs and alcohol, right? Suicide attempts, you got to think of those. Signs and symptoms. It depends on what caused it. And, you know, you think about poisonings, how much did they ingest over how much of a time frame, right? So the more they ingested, the faster they ingested it, the worse it's going to hit them. What's their weight? Because a lot of these things are weight-based as far as symptoms go. What's their health otherwise, right? So all those questions that you would ask for an adult. Always beware of mental status and then ABCs with these kids. Now, activated charcoal, it's the same dosing for a kid as an adult, 1 gram per kilo. Most adults, we just give them 1 tube, but minimal 15 grams. But poison control is the one to talk to, right? I mean, New Hampshire protocol says poison control or med control. Med control is going to call poison control anyway, so I'm just going to call poison control. And they'll tell you exactly how much to give this kid. So as we've said, most of these kids don't have heart disease. They can, right? I mean, we're seeing MIs in the 20s and 30s now that we'd have never thought about. And a lot of that's certainly activities, shall we say, but genetics. Genetics play a big part in heart disease. But it's still not very common. You know, if I've got a kid with chest pain, am I going to do a 12 lead on him? Yeah, I'm going to be safe. Okay. But keep in mind that most of these times with cardiac arrest, it's respiratory or volume or drugs. You know, could certainly be toxins. Okay, especially you know the older kids, right? So and you got five teenagers sitting around a house and one of their buddies is dead and you're doing CPR on them. They're not going to tell you shit because they don't want to get in trouble. Okay, so just keep that in mind. So when it is a heart problem, it's usually, like I said before, congenital, which could be a hole somewheres or a valve that's not working, or it could be a conduction defect, you know, so within the electrical system itself, or so left ventricular hypertrophy. So hyper means bigger. So the left ventricle is enlarged. And so it doesn't work as well as it should. Usually with that, a lot of times that's kind of a result of a disease like a pericarditis at some point, things like that. Shock and trauma in kids. Most commonly, it's blunt force, right? Whether it be punch, kicks, fights, falls, cars, bicycles, motorcycles, jumping off shit, right? Oh, the rope swing. Oh, yeah, this is a great idea. It's only a 75-foot drop to the water. And at that height, water's like cement, right? Or, you know, there's my buddies towing me on water skis when I couldn't water ski well. Hey, watch this, and they whip me around a corner at, a high rate of speed so they can watch me tumble across the, I quit water skiing. But it was more because I had, great friends. But blunt force injury, okay? The smaller the kid is, the more likely they are to get injured by an airbag. So kids are not supposed to be in the front seats, right? Up until the time they don't need to be in a like a booster seat, and I think that's like 8 or 9 years old if I remember correctly. I don't know that I was ever in a car seat. I was probably just laid on the back seat at some point, but we've certainly gotten better about that. So they should be in the back seat. They should be facing backwards. So like my grandson, my daughter's babysitting my grandson. He's in the back seat in a car seat, and she's got mirrors set up. And I imagine his mom and dad do too, but I haven't seen them in their cars. But so that because the kid's facing backwards. We look at trauma. It's the same. That physiology, that first piece of it, the vital signs. Glasgow less than 14, systolic less than 90, which, if their blood pressure is supposed to be 84, then 90 isn't a good, we can't use that. So we look at the rest of it. Glasgow less than 14, respiratory rate less than 20 in a kid, in an infant, less than 20. Right? Because they should be breathing more. That means they're failing. Remember, as they fail, respirations fail. And then we look at the rest of, the anatomy of it, the penetrating injuries. No difference in the kids than there is in the adult. The flails, long bone injuries, crushing, degloving, amputations above the wrist or ankle, pelvises, skull fractures, and paralysis. They go to a trauma center. And preferably an appropriate pediatric level. Now, Portsmouth, I've mentioned this a lot. Portsmouth's a very good trauma center. They are an adult level 2, pediatric level 3. Concord Hospital, level 2, adult, pediatric 3. I know Parkland's an adult 3. I think there are 4 for kids. Dartmouth's a 1 for adults. I don't know if there are a 1 or a 2 for kids though, right? So given the choice, you take these kids to the appropriate pediatric level trauma center as well. And then the mechanism of injury. So for a kid, a fall greater than 10 feet or 2 to 3 times their height. The rest of it is the same. The intrusions, the ejections, the death. 20-mile-an-hour impacts with a pedestrian or a bicycle. They get run over, they get thrown over, they get bounced. Motorcycles over 20. Now, motorcycles over 20, I was riding motorcycles at 9 years old that would do 60. So it's not super hard to run into a 9 or a 10-year-old who's dumped a motorcycle at 25, 30, 35. I mean, you go to the racetrack in Epping, the motocross track, and they got kids out there on 80s and 100s, and they're moving. So mechanism of injury, big deal. Special consideration, children should be preferentially triaged to pediatric capable trauma centers. That's the only difference in this scheme. Now, remember from the first few slides, these kids don't have the muscular strength for protection. Their ribs are more pliable, right? That's why we were talking about all this way back in the beginning, because of trauma, all right? And, if I get hit, my wife runs me over later with her Equinox, right? She slams right into me at 60. It's going to take out my femurs and my pelvis, right? And then I'm going to slam down into the windshield with my head. A kid gets hit by an Equinox, he's going to buy that girl right in the chest, So you got to think about size and size of the vehicles and all those things, okay? So head and neck, multiple internal organs. 3 most common causes of pediatric trauma death. Hypoxia, right? We've talked a lot about bagging patients. Trauma patients, if you look at this and go, this is a multi-trauma patient, he gets a non-rebreather or a BVM. Okay, this is not American Heart Association cardiac 95 and above. If you go, holy shit, he's a trauma patient, he gets a non-rebreather, or you bag him. Okay, massive hemorrhage. So what's going to kill him first, right? My A, my B, or my C, and tourniquets, hemostatics. Medics can give a thing called TXA, transischemic acid, through an IV, and that helps the clotting cascade work. So like if I'm intercepting with you and you have somebody who's been hit by a car and they're shocky or they have a lot of belly pain, I'm going to dump some TXA into their IV and help buy some time for that trip to the trauma center. And then, so hypoxia, massive hemorrhage, and TBIs, right? So those are the 3 most common causes of death in these kids, which is actually kind of the 3 most common for adults too. But so maintain the head if you can, neutral position, that folded towel under their shoulders. So you put somebody, it doesn't matter whether you're bagging them or not, you put a little kid flat on your stretcher, you should put that blanket under their back. Lengthwise, torso, from like the tailbone up to their head, which keeps their spine straight. If you put it across their shoulders, you're going to get a dip, somewhere in their chest. So you want their torso nice and level and the head in a nice neutral position. If there's no gag reflex, oropharyngeal airway, and bag them. Pre-hospital endotracheal intubation in peds associated with worse outcomes. The reason for this is you have people intubating kids who shouldn't be intubating kids. In some states, rather, in the US, AEMTs are still intubating, and they don't have the experience in it. A lot of our paramedics don't have the experience in it. So being really good with BLS is best. Having some people available who might be able to intubate this kid without delaying and without screwing it up would be nice. But that's why you may not see some of these kids get intubated in the field. TBIs, shock, chest trauma, you got to start thinking about bagging them. Supplemental oxygen rate and depth according to patient size. So, if you're bagging them, 15 liters for good chest rise and fall, right? 30, 20, whatever size they are, right? Bag them at 20 a minute or 30 a minute. Do not hyperventilate them, because what happens with hyperventilation is you blow off too much CO2, right? Our normal levels are supposed to be 35 to 45. Ooh, 35 to 45. When you get down to 25 on these TBIs, their mortality rate climbs, I think it's like 700% if I remember correctly. I'm pretty certain it's 700. That's amazing. And the reason for that is you get to that magic number, roughly 25, and you cause so much vasospasm in the cerebral arteries that you end up causing a global stroke. They're not perfusing their brain. So on top of their head bleed, now they've got no oxygen to the brain. So when we talk about 20 for a pediatric patient, right, that's 6-year-old, your best way to judge this is, yes, 20 is the textbook answer, 20 is the test answer. Real life is 20 is the starting point. You put them on capnography. You put the capnography on the BVM and you're bagging. And you want, if it's a TBI, you want them 35, okay? If they get much below 35, slow down. If they get up to 40, 45, bag them a little faster. Aim for 35, okay? Some people will say aim for 30, The problem with that is it's super easy to suddenly find yourself below 30. So I like 35. It's a safe number, and it can help a little bit with intracerebral pressure, but you're not running the risk of stroking them out. Control hemorrhage, keep them warm. Remember that hypovolemia and hypotension tend to go hand in hand. Hypothermia rather tend to go hand in hand, and they cause clotting disorders, right? And that causes more death. So stop the bleeding. Don't pour a ton of fluid into them until the bleeding's controlled. Keep them warm. Keep them flat. Keep them oxygenated. And then just continue to monitor them. You know, so these guys, we're going to call them critical. We're going to do this every 5 minutes. If you see them get bradycardic, they are about to die on you. Okay. They get tachycardic first as part of compensatory measures, just like adults do. But as they fail, their heart rate then drops, and that's ugly sign. Cap refill.
Kevin, how low would it get?
Oh, like 0?
No, I understand when it's death, but like if you saw it downward trending, how quickly? Is it like, you know, you start off at 60 and it goes 40, 30, 20, or?
It could. It would depend on how bad their injury is and how fast they're decompensating. So like as an adult, right, let's say we're at 120, 130, 140, and our blood pressure starts going like 120 over 70, and 5 minutes later it's 110 over 60, and their heart rate will do that. It'll start to drop. And you see it start to trend down, that's your sign that you know, it's on, you know, it's happening. So if you weren't ventilating them, you should start. If you're an A and you haven't put any boluses into them, you should start putting some boluses into them at that point. You know, let's say you had this kid that was like 120, 120, 120, 120, 120, and you were like, I think he's got a belly from this motorcycle accident. And then you're like, but, you know, he wants to go to Exeter, and I think it could just be pain, but you see his pulse start to drop. It's time to go to Portsmouth. So, you know, that could be that final tool, kind of like final deciding thing. But once it starts to drop, I mean, if you've got this kid who's got a broken femur and his pulse is 130 and he's screaming, and you splint it and he goes, and his pulse drops to 100, that makes sense, right? But if you're in the back of the truck and nothing else has changed, right? Pain hasn't changed. His level of consciousness hasn't changed, and his pulse starts to drop, there's no good reason for that. That's the way I would look at that. Proper sized equipment. So this is a little pediatric spinal board, which were wonderful when we were using these. A lot of services didn't have them. We were putting kids in these KED boards, these extrication vests, and they work really well too. But an appropriate size, if you're in a system that's still boarding kids, appropriate sized boards would be helpful. And you can see this one comes across his chest, over his shoulders, across his chest, across his belly and pelvis, across his legs, and it's going to do a nice job of mobilizing him. If he's conscious, he's going to be kicking, fighting, and fighting it. They worked good, but it was hard to keep him in it, you know. And if you can't, and if the kid's fighting because he's in something, we're not immobilizing him, right? So again, the car seats work great. Like, let's say you're going to take the kid out of the car seat and put him in your ambulance's car seat. That's okay. but take him out of his car in his car seat, because that's still maintaining some form of motion restriction. And then you can transfer him to a board or to your car seat if that's what you want to do. Padding, we've talked a lot about under the shoulders and torso. And if you are securing him on some sort of a carrying device, hey, it could be a scoop to carry him out of a house. It could be a scoop to go from the car up the little embankment to your stretcher, you know, in New Hampshire, and then we're going to take him off it. But if he's small, you may have to pad up both sides of him so that the straps actually hold him in place and he's not sliding around on this thing, okay? Rule of nines for for burns rather. You know, the heads are bigger. So in an adult, the whole head is 9%. In a child or an infant, the head is 18. So we've got to take that away from someplace. We take it away from the legs. Because in an adult, the front of the legs is 9, the back is 9, so that's a total of 18. I'm a little concerned about the fact that they amputated this kid's hand in the picture, though, but what do I know? Oh, and some toes. He must be diabetic. So 9 for the arms, 18 for the chest and belly, 18 for the posterior thorax, 18 for the head. Kids have thin skin, so they get burned easier. Lower temperatures, shorter duration. Up at Memorial, they joke that it's not summertime yet until somebody comes into the ER from having fallen into a campfire. It happens every summer. It's usually a drunk adult, but it could be a kid running around the campsite and somebody trips and falls into the fire they're cooking s'mores on every summer. Okay, so a lot of these burns can be prevented. I think I told you guys once, if you want to go have a tour, well, with COVID, I don't know now, but oh, Jesus. Boston Shriners gave tours of their facility and would do department trainings on burns. And one of their nurse educators, who I've had teach a few times, said that between the burn centers and the fire departments and associations, they've almost put the burn centers out of business because it's so much better now, burn prevention and fire prevention, but it's still out there because a lot of these things can be prevented. 1 in 5 burns with kids tend to be neglect or abuse. So all burns on kids should be reported to be safe. So like they use this example where, and I think in Mass, all burns have to be because he used this specifically. They reported a hot water burn and it was an accident. The parents there was no doubt. Nobody doubted the parents. The water got turned up a little hot. The kid stepped into it himself and got burned. But they reported it because it brought the town into the picture. And the problem had been this was an apartment building, and the people had been complaining that the water temperature was too hot, and it turned out that the water heater had been turned up to 140. And, you know, I think it's either 120 or 125 is max by code. And so the town contacted the landlord and said, you got to turn it down. Yeah, I'll get to it. No, you'll get to it at $500 a day fine. And so by reporting this kid getting burned honestly and by accident, it helped everybody in the building. Okay, so don't think of it as just ratting on parents. Sometimes it's an issue that something can be addressed. Drownings, submersion in liquid, highest incidence in toddlers and adolescent males, right? The 15-year-old boy, here, hold my beer. But the little kids, they wander off. That was my first pediatric arrest, not SIDS, but pediatric, 2-year-old, sitting out front with mom. Mom ran inside to answer the phone, came back out, the kid wasn't there anymore. He was like 200 yards away, face down in a pond. He saw his opportunity to go explore when mom ran inside. Okay, so bathtubs, swimming pools, ponds. Then as you get older, you got drugs and alcohol, and you got that showing off testosterone crap going on, and we do stupid things. Drowning, a combination of, hypoxia and acidosis caused by asphyxia. Most kids who will survive a drowning get rescued within 2 minutes. That makes sense, right? 4 to 6 minutes for brain death. But don't forget, cold water drownings can be up to an hour or 2, okay? We had one here in New Durham 25 years ago, and she was under for, I think, 45 minutes. She was not, you can Google her. She was very well known through the area because of this. She was not, she had lots of deficits. No speech, wheelchair bound, etc. But considering the alternative, her parents were extremely thankful, right? That because they got another 20 years with her. She died a year or 2 ago. I think it was pneumonia. We used to see her a lot with pneumonias because she was wheelchair ridden, But asphyxia. So with drowning, they get they asphyxia, hypoxic. They go into cardiac arrest. We resuscitate them. They get acute respiratory distress syndrome, which is damaged lungs, and their organs go into multiple organ failure. And it's a huge fight to keep them alive long enough with enough help for their body to kind of repair itself. It's a long battle. If they're in warm water, if they're still in the water, rescue them if it's safe for you to do so. Otherwise, and this would suck, I can't imagine this, wait for rescue personnel while everybody's screaming at you and other people are swimming out to help rescue, and now you've got a mass casualty going on. Get them out of the water as soon as possible. ABCs or CAB with CPR as appropriate. Get them out of the water. If you know how they got in the water and you're not worried about trauma, don't worry about spinal. But if you don't know, you got to worry about it and do spinal restriction. And if you're not going to work them, they're that dead, don't transport them, right? A friend of mine, one of our old firefighters, drowned. Last seen at 4 o'clock in the afternoon. The dive team found him at 7 a.m. the next day. You're not going to transport him, okay? But if you work him and they were submerged, transport him. Don't do the 20-minute and call him on scene thing, right? Because, hey, he's been submerged. You got to think about that cold and dead versus warm and dead, okay? Cardiac arrest, chest compressions immediately with good airway management. I think that hopefully goes without saying. And know what the protocols are for hypothermia in whatever, state system, whatever we're working in, okay? Which is basically, they're not dead till they're warm and dead. Burns, this kid got set down on something hot. For some reason, these abusers think that if I am holding the kid and I lower him onto or into something hot, it'll shut him up. So you can see with this, it's the same pattern, just this burns worse. Stocking foot. They lower him into scalding water. So they'll say, well, he got in the tub. Well, first off, he's 14 months old. He didn't get in the tub himself. And second off, I don't jump in the tub with both feet first, right? You take a foot and you step into the water and go, ah, and you burn a toe or you burn part of a foot. You don't have what looks like socks, right? Whether they be tennis socks or crew socks and they call it stocking injuries because it looks like you've got this red sock on. That's abuse. You were lowered into the water. If it's your hands, they'll call it mittens. They force your hands into the water. So it can be intentional. It can be accidental, right? Which would be more neglect. But We got to report this stuff anytime you see these things. Now, treatment for that, sterile bandaging and transport. You got to report it. You have to report it. Not only for this kid's sake, but he may have siblings that are going through it also, right? Scene safety, don't blame the parents. Don't accuse them, because you got to remember they can refuse transport for their kid. So you could go into this scenario and go, we got to take him, and you know, you did this to him. And the parent goes, no, I'm not taking him. You're not taking him. I have the legal right to refuse. And in the time it takes for you to get a cruiser there, they could disappear. They could kill the kid. They could do any number of things. So don't be accusing. Don't, you know, be empathetic. Oh man, whew, I can't imagine how you feel. You know, with an accident like this, I bet you feel awful. Man, how about we take him into the ER, right? This is the one case where I'm gonna lie through my teeth to these people. Oh no, yeah, I'm with you. This is awful. Yeah, no, don't worry. It's not your fault, right? Get the kid to the ER, get him treated, and we'll get stuff done after the fact. I don't want to leave there without the kid. So this is one time I will bend the truth and lie through my teeth if I have to. When what you really want to do is beat the living piss out of them, but you can't, because you don't want to go to jail either. Because it's funny how that works. Document everything. So just document what you found, what you saw. Don't say patient was hit with a belt buckle. You describe what the bruise looked like. It was U-shaped. It was 3 inches by 2 inches. There was a thin strip of, it was a U-shaped bruise with a thin striping of bruise down the middle of it, right? That's a belt buckle. There was a bruise that, a pattern of small marks, approximately 15 of them in 4 rows that resembled a hairbrush. You could do that, but not, he was hit with a hairbrush, okay? And just be as specific as you can about it. He was left outside in his pajamas, and it's 34 degrees outside. Or he was found outside in his pajamas, and it was 34 degrees out. All right? So a lot of stuff with pediatrics. Let me stop sharing my screen. What do you guys got for questions, comments, thoughts? If I was a vigilante, it would be for child abusers. Yep. Oh, it would take them weeks to die. Weeks.
Or animals.
Yeah, but
I hate that.
yeah, they'd probably be days though. I'm not going to spend a lot of time with them. I'll just kill them. But kids, oh, they're going to suffer long.